A very warm good morning to all respected teachers, eminent guests, speakers, esteemed faculty members, seniors, colleagues, and my dear juniors. Let's begin this new year be a canvas on which we paint our dreams, a platform to nurture our ambitions, and an opportunity to create moments that define us. Let's pledge to embrace each day with optimism, to cherish our loved ones, and to be a beacon of positivity in our spheres of influence. I, Dr. Purva Gupta, wishes you all a joyful new year and endless possibilities and boundless happiness. We all are gathered here to dwell into the depth of knowledge and expertise in management and treating the acute trauma patients. This CME serves as a platform for us to share the insights, exchange experiences, and foster a collaborative environment in which we enhance our skills, capabilities in the realm of acute trauma care. This CME and workshop is organized in the Department of Anesthesiology and Critical Care in KGMU, Lucknow. For starting our first session, I would like to request our chairpersons, Professor Dr. Monica Kohli, ma'am, Head of Department of Anesthesiology and Critical Care, and Dr. MP Khan, sir, for Department of Anesthesiology and Critical Care, to introduce the speakers.
This is the first, you are all welcome to this first of a series of academic innovations of this current year. The first speaker is Dr. Major Vishal Arora. He is currently the Professor in Dept in Anesthesiology and Integral. He has various publications and he has also participated in many papers. He is quite an academic person. So without wasting much time, I am inviting him for his presentation. He is already said we gave.
Thank you, sir. Morning, ma'am. Morning, sirs. My colleagues and dear PGs. The topic given to me today is pathophysiology of trauma. I can understand it's very traumatic today to come in the morning, so it's right in the context. Now, trauma is defined as a tissue injury which can occur due to violence or accident and is responsible for initiating three responses, which can be hypothalamic, pituitary, adrenal. As we know, it's a stress response or immunological response, which is decreased resistance to infection, and metabolic responses, which is characterized by F phase, catabolic phase, or the anabolic phase. These responses are essential for restoring homeostasis and bringing life back to normal post-trauma. As per Van der Kolk, trauma occurs when both internal and external resources are inadequate to cope with the external threat. So a traumatic event can be defined as one in which we experience, witness, or confront actual or threatened death, serious injuries, or there is any threat to a physical integrity of self or another close to us nearby. Now, trauma can be classified into a major trauma or minor trauma. The major trauma is chiefly, which we'll be discussing about. It has the potential to cause prolonged disability and even death. While minor trauma is like falling while going down the stairs or falling, in which a basic first aid may be required. It excludes a disabling injury and obviously the death. So traumatic injuries can occur as a result of physical forces applied to the body. As we know, there is a concept of kinetic energy and potential energy. Potential energy is at rest, while kinetic energy is movement. So whenever a kinetic energy or potential energy disbalance occurs, a sudden application of potential energy or kinetic energy occurs to a body, trauma can occur. So trauma can be blunt trauma, penetrating trauma, or deacceleration trauma to be defined later. Blunt trauma is one in which there is a physical contact to the body. However, there is no penetration of soft tissues. it can occur in motor vehicle crashes, pedestrian, which can be rollover, lateral, frontal, or from rear, in which a whiplash injury can occur, which can be in as pedestrian versus vehicle collision or falls. These can result into contusion to brains, a pneumothorax, diaphragmatic rupture, bowel ruptures, or even a chance fracture, which is an unstable flexion injury at thoracolumbar spine. Now, whenever the body is moving and there's certain stop, like while applying brakes to a moving car rapidly, there can be acceleration, deceleration injuries. So it can result into acute SDS in brain, aortic tear, large vessel tear, avulsion of kidney, or splenic pedicle tear, which is quite common. Penetrating trauma. The trauma caused by piercing of blunt objects which penetrate our body surface is penetrating trauma. Example, gunshot wounds, impalement by wood or other foreign bodies, stab wounds. It's just a simple diagram, though it is not relevant in my context topic, but just to give you a brief idea. Any blunt or penetrating trauma to neck may result into noisy labored breathing or swelling and airway obstruction or compromise. While any blunt trauma from motor vehicle crashes or pedestrian versus vehicle crashes may result into chest injuries, pulmonary contusion, pneumothorax, rib fractures or broken ribs. While any trauma from motor vehicle may result into blunt or penetrating trauma to head, neck, chest, abdomen, groin, which may result into damage to large blood vessels, or even a fall from a height may result into neck or spinal cord injury or fracture of the spinal cord column. Now, another type of injuries are blast injuries. Most commonly, they are visible in war, but as in the current scenario, terrorist attacks are common, so it's also relevant in our context. It can be primary blast injuries entirely due to blast pressures, secondary blast injuries due to shrapnels or debris which are flying post blast, or tertiary blast injuries in which victim is hurled away or thrown away by the force of explosion. So it can be both blunt or penetrating. So penetrating trauma, our primary concern is a hypovolemia or hypovolemic shock due to loss of blood and hemorrhage. So this can lead to decreased organ perfusion. Acute blood loss is quite common, and mainly our vulnerable organs are kidneys, brain, heart, liver, colon, and we'll be discussing the cascades of autonomic nervous system which tries to restore them in the later part. While blunt trauma, as we have discussed, is only a physical contact with the body without penetration, and hemorrhagic effects are similar to that of penetrating trauma. Spleen is one of the most common organs to be injured in blunt trauma, while blunt trauma to liver chiefly results in venous hemorrhage rather than arterial. And inflammation and edema are the landmarks besides hemorrhage. So how does inflammation and edema creeps in? After traumatic injury, mast cells, as we know, are signaled to release histamine and bradykinin, and there's a vascular phase of vasodilatation and increased blood flow, along with the recruitment of WBCs and macrophages, which is the cellular component. So endothelium damage may lead to leaky endothelium, and finally seepage of fluid from post-capillary values into the interstitial space, leading to edema following the trauma. So hemorrhage, inflammation, edema, three things have been added to the trauma pathophysiology till now. So deceleration trauma. When there's sudden stop in motion lying in a moving car, a rapid application of brakes, this trauma can result, it's a deceleration. A stoppage to a fast moving vehicle or acceleration is deceleration. So large amount of neurochemicals and prostaglandins are released, and the tissue damage and blood loss are further exacerbated. It can be in form of concussions, contusions, counter-coup injuries. So counter-coup injuries are most common found when we brake the car because the head is moving and the object is stationary and head hit the front screen most of the times. So counter-coup injuries are very common, while coup injuries in which the object is moving, like a strike from rear and head is stationary. And penetration injuries are also there besides blunt injuries, deceleration trauma. So basic pathophysiology of shock and trauma is, as we have discussed, the loss of blood leads to decreased intravascular volume, decreased venous return, further leading to decreased stroke volume, cardiac output, blood pressure falls, hypoperfusion of tissues, further for prolonged periods may lead to multiple organ damages. So what is the cascadic response of body to avoid shock? First is activation of sympathetic nervous system, release of plasma catecholamines, endogenous catecholamines, vasopressin and norepinephrine to increase heart rate and cardiac output. Second is to increase the systemic vascular resistance via renin-angiotensin-aldosterone system, in which renin, which is released by juxtaglomeralar cells in macula densa, it converts angiotensin 1 to angiotensin 2. And angiotensin 2 acts as a vasoconstrictor and also causes the release of ADH, which limits water, which leads to water reabsorption and limits water diuresis. And it also limits baroreceptor reflex bradycardia, thus further maintaining the cardiac output. So activation of SNS and release of endogenous catecholamines first response. Second, increase of systemic vascular resistance by RAS system, that is renin and angiotensin, further releases ADH and limits baroreceptor reflex bradycardia. This is the response to avoid shock, a body endogenous response. Multi-system trauma includes more than one body system. These will be discussed in detail in later topics. It can be head and spinal trauma, chest or abdominal trauma, chest or multiple extremities trauma. Now, another important component of trauma besides hemorrhage, inflammation, edema, shock is the coagulopathy, which is a primary concern for today, which is the most devastating effect. Trauma-induced coagulopathy, as is common known as, or acute coagulopathy of trauma, is the same thing. It is a coagulopathy caused by trauma, and the inflammatory cascade is linked to the coagulation cascade in this setup. So there's tissue trauma, shock, and it provokes our endothelial immune system, plating and coagulation cascade. There's hyperactivation of these cascades, and it is exacerbated or worsened by hemodilution, hypothermia, acidosis. So there's a activation of coagulation and fibrinolytic system, which worsens the things of hemorrhage and inflammation, which the patient has been experiencing earlier. So in early hours, there's hypocoagulability resulting in bleeding, while in later hours or later trauma-induced coagulopathy, there can be a hypercoagulable state and venous thromboembolism and multiple organ failure. So trauma-induced coagulopathy has three components: activation of coagulation system, hyperfibrinogenesis, breakdown of fibrogen in an exaggerated context, and consumption coagulopathy. It resembles the DIC with fibrinolytic type, and there's a lethal triad of hemodilution, hypothermia, and H+ ions, acidemia. It can be called as triple S, though it is not triple S. As we know, it is used for vasospasm, triple S therapy. But there are three H here: hemodilution, hypothermia, and acidemia. So this is a brief overview. Trauma-induced coagulopathy can be synonym with DIC with fibrinolytic type, which has three components of coagulation activation: hyperfibrinogenesis and consumption coagulopathy, which is exacerbated by acidosis, hypothermia, and hemodilution. So a brief overview of coagulation cascade to understand this. There is an intrinsic pathway and extrinsic pathway, as we all are aware. Extrinsic pathway में tissue damage is there. Factor 7A is a cofactor for conversion of factor 10 to 10A, while in the intrinsic pathway, surface contact of endothelium converts finally factor 12 to 11 and then 9, and finally factor 10A along with factor 8 and 9A is the chief link between intrinsic and extrinsic pathway, and it converts prothrombin to thrombin and finally fibrogen to fibrin, and a stable fibrin clot is formed by activation of fibrin and factor 13A in the last. Now, another thing is, this is the same pathway. The difference is, as you can see, This is the anticoagulation pathway added here. So thrombomodulin, which is released by endothelium of blood vessels, it forms a complex with thrombin, and protein C is activated. So protein C and S, besides endothrombin, is the anticoagulation pathway. In addition, plasmogen is converted to plasmin, which also inhibits the clot formation. So this anticoagulation pathway and coagulation pathway act synergistically to maintain the body homeostasis. So coagulation activation, as we have discussed, procoagulants are released in massive amounts in systemic circulation. What are the procoagulants? Tissue factor, and factor 11A. So their levels are elevated. So it's a procoagulants are released, while the endogenous anticoagulant activity, which balances the coagulation, which is mediated by thrombomodulin protein C pathway. This is the anticoagulant activity. So this anticoagulant activity is impaired while the procoagulant activity is enhanced. So finally, thrombin generation into the circulation is enhanced. This thrombin generation is enhanced. Now there's release of tissue plasmogenic activator. It converts plasmogen to plasmin and initiates fibrin and fibrinogen degradation. There's breakdown of fibrogen in large amounts, in massive amounts. Hence it is called hyperfibrogenolysis. And hence there's a elevation of D-dimer and fibrin degradation products as fibrogen is broken down in large amounts. As the trauma cycle continues, coagulation activation and hyperfibrogenolysis simultaneously occurs, and finally the coagulation factors and platelets are consumed as it is common in DIC. So there's consumption coagulopathy which takes over, fibrogen level decreases much more, and there's further dilution of fibrogen due to massive transfusion and over-infusion of fluids and blood, and this may lead to poor outcome and massive bleeding. So there's a thing known as acute coagulopathy of trauma shock theory. What happens, what we have discussed earlier, this side. Thrombomodulin binds with thrombin to activate protein C, which further suppresses the prothrombinase complex, that is factor 5A complex, and thrombin formation. Hence the endogenous anticoagulant activity is disrupted. So this activity is disrupted here. Coagulation cascade is activated much more, but after multiple activations, consumption coagulopathy takes over, and finally the system is depleted of the coagulation factors. Okay, so activated protein C breaks down plasmogen activator inhibitor. So what does plasmogen activator inhibitor do? Plasmogen activator inhibitor suppresses fibrinolysis, and activated protein C breaks down this activator inhibitor. Hence the fibrinolysis is further activated. So this will be discussed later. Scene size up, primary assessment, secondary assessment, full body scan or rapid head to toe in the subsequent lectures by other speakers. So what can be seen in a case of trauma? A basic injuries to head. It can be disability. Injury may not be visible. There can be bleeding, swelling, concussion, contusion inside. There may be obvious signs present or absent. Frequent neurological examinations are hence must. Injuries to neck and throat are more deadly and serious injuries. Airway problems. Dept, BTLS, which will be discussed later. Okay, deformity, contusion, abrasion, penetration, burns, trauma, laceration. There can be swelling to brain. Penetrating injuries may further result in air embolism, or crushing injuries may cause cartilages of upper airway larynx to fracture. Injuries to chest may manifest as broken ribs, bruising of heart, tearing of large vessels. So there can be open chest wound which need to be assessed every 5 minutes, and again Dept, BTLS to be done, lung sound and chest rise to be monitored. While injuries to abdomen may include solid organ injury or a hollow organ injury. Solid organs like liver, spleen, pancreas, kidney. Okay, they may tear, lacerate or fracture, while hollow organs may be stomach, large and small intestines or bladder, which may rupture and leak digestive juices. So large vessel rupture is also common in abdominal injury like aorta, vena cava. So what are the lab investigations we need to go for in trauma? CBC, hemoglobin, hematocrit, platelet count, consumption coagulopathy and platelet count will be decreased. Serum electrolytes, massive crush injury, potassium levels may be very high. Burn serum creatinine may be raised due to hypovolemia. Same for liver markers, AST, ALT. Blood type and cross match required. APTT, PTNR deranged. Fibrinogen levels decreased. FDPs may be increased. D-dimer increased. CKMB increased in crush injuries. Glucose may also be increased as a part of a stress response. And basic ABG to rule out metabolic derangements. Thank you.
Thank you so much.
Sir, thank you.
Thank you so much, Professor Vishal Arora, for your excellent talk on the mechanism of trauma, pathophysiology, coagulation cascade, lethal threat of trauma. It was an excellent lecture to start with. And thank you, gentlemen, for organizing this Acute Trauma Care 2024, first CME of this year. I would like to invite the students to ask any question. Ask something. Now I invite my colleague, Dr. Hemendra. She is a research professor at the Department of Anesthesiology for a talk.
A very good morning to all of you. My topic for today's talk is ABC and damage control resuscitation. I think Dr. Vishal has already covered the pathophysiology part of the trauma. So whenever we talk about trauma, slide show. Whenever we talk about trauma, most of the time it is polytrauma. That means involvement of more than one system. It may be multiple fractures, there may be associated head injury, spinal cord injury, maybe thoracic injury, abdominal or pelvic injury. So most of the time it is polytrauma. Since it is a multi-system injury, so it needs management by a team of physicians and surgeons. So it is basically a teamwork. When we talk about the global burden of trauma, it is the leading cause of death between the ages of 14 and 45 years. Most of the bread earner of the family, they lie within this age group. And it is the third leading cause of death and disability in all age groups. Globally, more than 9 people die every minute from injuries or violence. And this amounts to around 5.8 million annually. And out of this, motor vehicle crashes alone causes more than 1 million deaths. Earlier, there used to be the trimodal death distribution, in which there were 3 peaks of deaths. One was immediately, within seconds to minutes after the trauma, that was caused mostly because of either the severe head injury or high spinal cord injury or massive blood loss because of either the rupture of heart or aorta. So nothing can be done about this except prevention. Then comes the second peak of death, which is mostly caused by the intracranial bleed, the subdural hematoma, the epidural, the chest injuries, abdominally, or bleeding from any other sources. So this is basically the second peak of death that we address by acting in this golden hour after trauma. If we intervene properly, then we are able to save so many lives. And then comes the third peak, which occurs mostly in the ICU several days or weeks after the trauma, maybe because of sepsis or organ failure. And this peak of death is also influenced by the management of our patients in the early hours after trauma. So nowadays, this trimodal distribution has almost become bimodal. This is because the better implementation of acute trauma care and better road safety rules and all, prevention. Coming to the management of trauma patients, we normally adhere to the ATLS concept of management that is followed worldwide in more than around 100 countries all over the world. And that basically talks about the ABCD approach towards management of any trauma patient for evaluation as well as for management. So why is this particular sequence for management? This basically depends on treating the greatest threat to life first. Whatever is going to kill our patient first should be addressed first. That's why A will be followed by B, followed by C, because A kills first. One more important thing about managing trauma patients is that we don't need to have a definitive diagnosis, and we don't need the detailed history of the patient before intervening. We have to intervene immediately on receiving any trauma patients, unlike all other patients in which we go for a detailed history followed by a detailed physical examination and investigations. Then we reach a diagnosis and then we manage our patients. But the story is entirely different in trauma patients. Then time is of the essence, and that is emphasized by the concept of golden hour, which emphasizes the urgency necessary for successful treatment. So it is not intended to mean exactly the 60 minutes after the patient has sustained trauma or the patient has arrived the trauma center or the emergency room. Basically, it provides a window of opportunity in which if we intervene, then we are able to decrease the mortality and morbidity by many folds. The concept is, the importance of time is more emphasized recently by the concept of platinum 10 minutes. And when we talk about ATLS, it provides a common language and it gives us a structured approach for the management of any trauma patients. And it may or may not be the best way to treat any trauma patient, but yes, it is one safe way to treat our patients, and is applicable in all sorts of facilities, even in a village, in a place where the rudimentary facilities are available. There also it is equally can be implemented. Basically or broadly, there are 4 steps. First is primary survey along with resuscitation of the patient. That is followed by secondary survey and definitive care. So this algorithm depicts the stepwise approach. As you can see, our management begins even before the patient arrives in the form of preparation. We need to prepare with all the equipment, the drugs, the temperature of the emergency room that has to be maintained. We need to pre-warm the fluids, and also, if possible, we can inform the OT technician, the blood bank, the OT personnel or the surgeons. So all comes under preparation. That is followed by primary survey, in which there is simultaneous assessment as well as intervention. As you can see here. Now coming to all the steps, A stands for airway with restriction of C-spine motion. Restriction of C-spine motion is very, very important when we are dealing with the trauma patient, because we don't want to do further damage. Suppose there is an incomplete cervical vertebral injury is there, C-spine injury is there. We may convert it into complete injury if we are not restricting the motion of the C-spine. So till the time it is ruled out, we should not do the movement of C-spine. Otherwise, the patient may become paraplegic or quadriplegic. Then comes maintenance of breathing and ventilation. That is equally important in order to provide oxygen to the vital structures of the body. Then comes circulation with hemorrhage control. D stands for disability, which is basically the neurological disability and not the orthopedic one. And E stands for exposure, complete exposure of the patient, but at the same time taking care to avoid any kind of hypothermia in order to look for any missed or hidden injuries or source of hemorrhage. There are certain special groups like extremes of age, obese patients, pregnant ladies, in which we have to take certain special precautions. But even in these patients, the priorities always remain the same, that is A, B, C, D, E. we can do a quick assessment whether our patient is having an intact patent airway. We can simply ask the patient what happened and what is your name, such questions. If the patient reply in a proper way, then we know that any talking patient has got a patent airway, and since the speech is there, air movement is produced, so the ventilation is also adequate, and cerebral perfusion is also intact, so circulation is also not impaired much. So this much information we can get quickly. There are so many signs and symptoms of airway compromise. We all know that, so we should look for them and intervene accordingly in order to maintain the patency of the airway. And even if the airway is patent, at times we need to go for definitive airway. We need to intubate the patient. For example, the patient has sustained burn injury with inhalational injury. There can be impending laryngeal edema. Later on, the airway may get compromised. So we need to intubate the patient before that. Patient may require ventilation. And for putting the patient on ventilator, we may need to intubate the patient. Or if the patient has got poor GCS, less than 8, we need to go for a definitive airway. What all do we have in our armamentarium for the management of airway management of any trauma patients? First of all, we should give supplemental oxygen to all the patients. It may be as high as 10 to 15 liters per minute. Then there are certain basic techniques in order to establish the patency of airway, like the chin lift and the jaw thrust maneuvers. Obviously, we need to restrict the C-spine, so head tilt is not allowed. Then there are basic adjuncts like oral and the nasal airways, the nasopharyngeal airway. They have got their own limitations. Like oral airway should not be inserted if the gag reflex is intact, and nasal airway if there is any signs and symptoms of fracture of the base of the skull. Then comes the role of definitive airway. If the airway patency cannot be established by any other mean, then we should go for a definitive airway. That means a tube within the trachea with its curve inflated below the vocal cords. So there are two types of definitive airways. We all know one is the endotracheal intubation and second is a surgical airway. When we talk about surgical airway, there are two kinds of surgical airway, mostly cricothyrotomy and tracheostomy. So in trauma patients, we will go for cricothyrotomy over tracheostomy. Why? Because it is easier to perform, takes less time and is associated with less blood loss as compared to tracheostomy. Moreover, in tracheostomy, you may need to overextend the neck, which is not allowed in these trauma patients. So we will definitely go for cricothyrotomy. And if you're not able to perform surgical cricothyrotomy, then another option is needle cricothyrotomy in order to buy some time, in order to convert this emergency into an urgency so that definitive airway management can be done later on. You need to predict difficult intubation. Obviously, all the trauma patients poses some degree of difficulty because of the cervical collar, the restriction of neck movement. So that does pose difficulty. Besides that, we have got lemon mnemonic. L stands for look externally for all these features that is described here. Then E is to evaluate the 332 rule, that is the inter-incisor gap of 3 fingers, then the hyomental distance and the thyroid distance. And M stands for the Mallampati grading, O is for any kind of obstruction, and N is for neck movement. In case of difficult airway, we should never hesitate to call for help. Even if we think we are qualified enough, but 2 persons are always better than 1. So we should always call for help. We should prepare for difficulty. What does mean preparing for difficulty airway? Preparing for it means preparing for failures. What if plan A fails? What if plan B fails? So we should be ready with our plan A and the backup plans, the plan B, plan C, etc. We have to decide whether we are going to induce the patient and give muscle relaxant or we are going for an awake intubation. And if we are stuck up, we can go for use of gum elastic, bougie, combi tube, laryngeal tube, airway, the supraglottic devices, or we can straight away go for surgical airway. There should be some airway algorithm in place for difficult intubation in all the centers, in all the emergency rooms, and that should be adhered to. After airway, establishing the airway patency, next comes breathing and ventilation, which is equally important. We need to assess and ensure adequate oxygenation and ventilation. We will look if the respiration rate, chest movement, air entry, all are adequate or not. If there is any kind of thoracic injury or inadequate ventilation, that needs to be identified through all the signs and symptoms. There are certain chest injuries which are immediately life-threatening. So we need to assess that during the primary survey itself, and we need to manage it there and then. For example, if the patient is having a tension pneumothorax, so you need not wait for investigations for the chest X-ray to come to make the diagnosis. It is a clinical diagnosis. You have to immediately diagnose and immediately intervene in the form of needle decompression, followed by chest tube, insertion of the chest tube. There are many other chest injuries which are potentially life-threatening, which can be dealt with later during the secondary survey. So we need not bother about them at this point of time. Chest injuries I'm skipping because that will be covered in the next lecture, I suppose. Next component of primary survey is circulation, which always includes control of the hemorrhage. For that, we need to understand what is shock. Shock is basically an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation. It is basically a generalized state of hypoperfusion. There is inadequate oxygen delivery to the tissues, to the organs. There are certain compensatory responses in the form of release of catecholamines because of since oxygen delivery is inadequate, there will be anaerobic metabolism leading to lactic acidosis. Cellular dysfunction will be there, and finally cell death can occur. So we all know about the basic pathophysiology that the cardiac output is heart rate multiplied by stroke volume. So in this setting of inadequate blood volume in this hemorrhage, traumatic hemorrhage, we know that in order to maintain the cardiac output, the compensatory increase in heart rate is there. So tachycardia is the earliest measurable circulatory sign of shock. There are other compensatory mechanisms in order to divert the blood to the more important and the vital organs of the body, that is the kidneys, heart, and brain, from the relatively less important organs like skin, muscular system, and the visceral circulation, etc. So it's very important to restore the venous return to normal by locating and stopping the source of bleeding. Then only we will be able to save the patient. Nowadays, we are aware of this particular entity called trauma-induced coagulopathy that further aggravates the bleeding. Whatever bleeding is there because of direct injury to the tissues, to the blood vessels. Further, there are many other external factors also like hypothermia, coagulopathy, this particular coagulopathy, then acidosis, all are going to aggravate the further bleeding. So that should be kept in mind while we are managing shock. The very first step in the initial management of shock in trauma patient is to recognize its presence. Then only we will be able to intervene. So how to recognize? There will be hypotension and tachycardia, isn't it? But before that, there will be many other signs and symptoms. The peripheral manifestation, the skin will be cold and diaphoretic. There will be altered level of consciousness. Patient may have anxiety. There will be decreased urinary output. So all these point towards shock. Any injured patient who is cold to touch and is tachycardic should be considered to be in shock until proven otherwise. So based on the clinical presentation, we can have a rough idea of the amount of blood loss that has already taken place. And accordingly, we can plan whether we can wait for blood to arrive and meanwhile we can manage with the crystalloid, or do we need to go for massive transfusion protocol needs to be activated. So these things can be decided based on the clinical features, which tells us the roughly about the amount of blood loss. For example, if our patient has the blood pressure is still normal, the systolic pressure is still normal, only the pulse pressure is diminished because of increased diastolic pressure, and there is slight tachycardia, the urine output is not diminished much. So we can have an idea that our patient is in grade 2 shock. So must be up to 1 or 1.5 liters blood has been lost. So we can order blood immediately and we can go for blood. Nowadays, the concept of early use of blood products is there. Base deficit is very, very important, and it guides us in not just in the diagnosis, but it also guides us in managing the patient and prognosis. Now, we need to intervene in any shock patient, hemorrhagic shock basically, because of the blood loss. So what vascular access do we need? Should we go for a central line or should we go for a peripheral line? Peripheral. We all agree that we should go for a peripheral line because we need to give high flow. And because of short length of the peripheral cannula, the flow will be much higher, because we all know that the resistance is directly proportional to the length of the tube and inversely proportional to the fourth power of the radius. So we will go for peripheral axis. Wide bore, wide bore peripheral cannula should be inserted in all the trauma patient initially for fluid resuscitation. We can go for a 16 gauge if it's available. What type of fluid? It should be warmed crystalloid, balanced crystalloid solution should be given, and how much to give? That is the $1 million question, how much to give? Earlier, we used to go for aggressive resuscitation. The guidelines used to say that we can give 2 liters of balanced crystalloid, and then we have to assess the response. But nowadays, we have to restrict the volume resuscitation. The maximum allowed is 1 liter. Why don't we give so much of large volume of crystalloid during the initial phases before the control of hemorrhage has taken place? Because that has got its own risk. That will further increase the blood pressure, which will again promote blood loss. Then there will be diminished viscosity of the blood. There will be dilutional coagulopathy. There will be hypothermia. So all these will be detrimental. So we need to go for a restrictive. Maximum 1 liter of balanced crystalloid solution we will give. And this aggressive fluid replacement will also aggravate this already existing lethal triad of trauma, which consists of coagulopathy, acidosis, and hypothermia. We need to break this vicious cycle in order to save our patient. So for early resuscitation, we will keep slightly hypotensive resuscitation will be there. So our goal should be to maintain systolic between 80 to 100 millimeters of mercury. If the patient has sustained severe traumatic brain injury, then we can go for a slightly higher, 110 millimeters of mercury. We need to maintain the hematocrit on a slightly lower side, lower normal range, 25 to 30% platelet count at more than 50,000, and the core temperature above 35 degrees Celsius. We need not be very aggressive during the initial early resuscitation. That is before the source of hemorrhage has been controlled. The surgical intervention or the damage control surgery has been done. However, during the late part of resuscitation, after control of bleeding, we can go for a higher target of blood pressure. We need to normalize everything now. The coagulation status, the electrolyte balance, body temperature, and urine output. We can target a normal. And lactate level, like I said, that base deficit and the lactates, they are a good indicator of our resuscitative measures. What do we mean by balanced resuscitation? Basically, balanced resuscitation means that we need to balance the risk of increased hemorrhage and the risk of hypoperfusion. So we have to choose between the better of the two monsters. So we have to accept a lower than normal blood pressure, that is hypotensive resuscitation or permissive hypotension. Early use of blood and blood products like the components, the PRBCs, FFPs, and platelets is recommended, and minimal use of crystalloids. Nowadays, even the people are going for resuscitation using blood, even before crystalloids or simultaneously with the crystalloids. Now coming to the second part, that is a damage control resuscitation. This is basically a systematic approach to the management of trauma patient with severe injuries that starts in the emergency room and continues through the operating room and the ICUs. It aims to maintain circulating volume, control hemorrhage, and correct the lethal triad of coagulopathy, acidosis, and hypothermia until the definitive intervention is appropriate. So it has got 3 main components. One is permissive hypotension, second is hemostatic resuscitation, and third is damage control surgery. Hemostatic resuscitation means we should target a normal coagulation profile of the patient. We will go for blood component therapies and other hemostatic factors like antifibrinolytic agents, calcium. So all these should be given to the patient in order to do a hemostatic resuscitation. One thing I would like to emphasize, there is no role of vasoconstrictors in the management of these patients. That is hypovolemic shock, hemorrhagic shock. And fresh whole blood is also considered nowadays. Earlier it used to be, we used to say few decades back, it was considered a thing of the past. But now in Western world, they are going for fresh whole blood, which is basically low titer O whole blood, LTOWB, they say it. So we don't have this whole blood available here, but yes, this is also very useful. Then the role of point of care. whole blood viscoelastic tests, they are very, very important, like the thromboelastography, the rotational elastometry. Trauma ke patients mein, they are very, very useful, and they are being used everywhere in order to guide the component therapy for doing hemostatic resuscitation. So there are so many guidelines, the clinical practice guidelines given by the Joint Trauma System, which is being updated from time to time. And the latest addition in those guidelines is regarding tranexamic acid, the antifibrinolytic agent, and the calcium. They say that calcium should be given while giving the first unit of blood or after the first unit, and later on it should be repeated after every 4 units of blood. This update has come recently in 2023. And regarding tranexamic acid, earlier we used to give 1 gram of Tranexa, but now the recommendation is you can give 2 gram of Tranexa within 3 hours of sustaining the trauma. After that, we need to, whatever resuscitative measures we are doing, we need to monitor the response of the patient, and accordingly, we can classify the patient in 3 groups. One is rapid responder, transient responder, and the minimal or no response. Rapid response means there was minimal bleeding, maybe 10 to 20% of the blood volume loss is there, and it has stopped. Transient response means either the blood loss is moderate to high, or it is continuing, the bleeding is continuing, hemorrhage control has not been done. That's why the patient is again landing up, and we are not able to resuscitate the patient. Then third group is minimal or no response if it is a massive blood loss and continuing blood loss. So accordingly, we will call for surgeon, or we may need to take the patient to the operation theater immediately for control of hemorrhage. Massive blood transfusion protocol we all should know, and that should be in place in all the centers, because that has been shown to be very effective in decreasing the mortality. And most of the shock packs that are available for use in trauma patients, they consist of all the 3 components in 1:1:1 ratio. That is the FFP, the blood. There are so many studies which have analyzed the different ratios. The most recent, the proper trial, which was published in JAMA in 2015, that suggests a ratio of 1:1:1 to be very, very effective in all our patients. Like I said, fresh whole blood, nowadays it is being used primarily to the most given to the most severely injured military combat casualties. Crash 2 study, in which, like I said, the use of tranexamic acid, that is found to be very useful, especially when given within 3 hours of the trauma. However, recently, there is a term called fibrinolysis shutdown, because of which many people are saying that it's not at all useful in trauma patients, and it is only useful in certain group of patients who are having increased clot-lysis, as shown on thromboelastography. So this is another concept you should be aware. Maybe you will be asked. This is one example of MTP, and there are certain trauma scores which guide us to decide whether we should go for massive transfusion protocol. Like one is TASH score and another is the ABC score, or assessment of blood consumption. These are the most popular ones. Role of recombinant factor 7A is no more. It's not recommended. Earlier also it was only an off-label use, was not recommended by FDA, but now it is recommended that you should not use it. Then management of shock, the second step. First, recognize that the shock is present, then to identify the probable cause of shock. So it can be hypovolemic, or there can be other causes. However, in all the trauma patients, shock is mostly due to blood loss. We will assume it to be because of blood loss, and we will our approach will be like that. Obviously, we will keep all these other causes in mind. There are 5 major causes, or you should say source of hemorrhage in trauma patient. The mnemonic for that is 1 on floor and 4 more. So 1 on floor means basically the external hemorrhage that is visible from outside. And the rest are the internal hemorrhages that mostly occurs either in the thoracic cavity, the pelvis, the long bones, and the abdomen. Accordingly, we will use the diagnostic, the adjuncts, and we will go for the definitive management accordingly. Like for abdomen, we can take help of FAST. FAST is recommended in all the patients of trauma to rule out any collections, And if the patient is fast positive, we may have to take the patient for damage control surgery. Immediately, we need to take the patient in the OT and we have to intervene. There are different methods. Fast is very important, and chest X-ray, pelvic X-ray. And besides surgery to control hemorrhage, there are many other means to control the hemorrhage, like direct pressure, use of tourniquet, reduce pelvic volume by using pelvic binders in case of pelvic fractures, then hemostatic agents, antifibrinolytic agents, calcium and other things, splinting of the fractures if it is a long bone fracture, then angioembolization and hemostatic resuscitation. Damage control surgery basically means that at this particular point of time, the surgeon need not go for definitive surgery, only that much which is required to control the hemorrhage so that other resuscitative measures should be taken and patient needs to stabilize. And rest of the things can be done at later stage. Next comes after management of C comes D, disability is neurological. We need to assess the patient repeatedly for any deterioration in neurological condition. And if required, if any indication of head injury or neurological injury, we can inform the neurosurgeons and take help from them. And E is the exposure of environment in order to look for any missed injuries. So this is basically a summary. So to summarize, all trauma patients should be assessed using the universal ABCDE approach. Favorable outcome for a trauma patient demands an integrated team effort. Initial management is dictated by patient's immediate physiological requirements for survival. As we have seen, the anatomical injuries can be taken care of later. So during primary survey, we need to focus only on the physiological requirement of the patient. All efforts during resuscitation should focus on reversing the lethal triad. Damage control resuscitation combines three things: permission hypertension, hemostatic resuscitation, and damage control surgery. Massive transfusion protocol should be implemented in each trauma center. Thank you so much.
Thank you, Dr. Hemanta, for your excellent talk. You are the exact person to talk on this because you have been an ADS inspector.
Yes.
So she touched upon the need for because patients are unanticipated and undifferentiated, therefore she touched upon the need for this ABCD and D approach, covering airway threats, breathing threats, circulatory threats. So excellent talk by you. Thank you so much.
Thank you.
Any questions?
या तो सबको समझ में आ गया या सब सुन रहे हैं.
So what's the difference between massive transfusion and massive transfusion protocol?
Anyone?
Anyone? What is massive transfusion? Anyone of you?
Definition of massive transfusion. How much blood in how much time or how many units? अभी बताएं, हाँ? Whole blood volume within 24 hours or half the blood volume within 3 hours or more than 10 units in 24 hours. So that is massive transfusion.
There is massive transfusion. Then what is massive transfusion protocol? MTP?
So that is a complete topic. You may get a 10 marks question in your exams on massive transfusion protocol only. So that is, if the patient is having severe hemorrhage, you need to activate this massive transfusion protocol. There are so many protocols. One example I had shown here, in which the blood bank needs to be informed immediately regarding this, and they will give you either the shock packs, or suppose if the cross-match blood is not available or it takes time for cross-matching, they can go for a low titer O negative blood can be issued along with the other components. Okay, and you have to be in touch with the blood bank, and you have to inform them that yes, we are now activating the massive transfusion protocol, and when you have to stop it, that also you need to inform them, and you coordinate with them. Like I said, there is a role of the point of care viscoelastic tests that will guide you. Okay, and if shock packs are available, that consists of 1:1:1 ratio of fresh frozen plasma, packed RBCs, and the platelets. If platelets are not available, even 1:1 ratio of FFP and blood you can go for. So that is a huge topic in itself. So you need to study that also in detail. Okay. Any other questions?
Thank you, Dr.
Thank you so much, ma'am.
We a little break because Dr. Vishal needs to leave, so we'd like to felicitate him. Dr. Rafi, can you felicitate?
I request Dr. Monica Foley ma'am to felicitate Dr. Vishal Arora sir.
Now I would like to welcome Dr. Baba Jaspal, a fellow colleague and additional professor in the Department of Trauma Surgery. He has done MS General Surgery followed by MCH in Trauma and Surgery from CME, New Delhi. Welcome, Dr. Baba Jaspal. So, talk on critical topic that is thoracic and lateral trauma.
So, good morning, respected all. So, it's a pride privilege for me to have my teachers as a chairperson over here. So, my talk today is all about thoracic and vascular trauma. So, the first picture actually depicts how, as a trauma surgeon, we used to see a thoracic trauma. It's not limited by anatomical boundaries. It's a situational awareness which governs the decision-making capacity of a trauma surgeon. And as philosophy goes, actually we need right patient at right time, in the right hands, and at the right place. It's like connecting the dots. If you want to survive our patient, we need to connect all the dots. It's not clear picture at the very first instant when we see any patient. It's never regionalized, like it's not a thoracic trauma itself, it's a polytrauma always. So, as a layman could see, trauma is a disease, but for a trauma surgeon, it's beyond agent, environment, and vector interaction. So, we'd like to see it in a prismatic view, like we need to know what is the timeline of this trauma and what is the place of care which we are providing to our patient. What is our team? What is the team's composition? Where anesthesiologists are there or not? Intensivists are there or not? Orthopedician, neurosurgeon. It's a truly a multidisciplinary approach to make survive any trauma patient. And then we need to know mechanism and physiology and anatomy of the injury. So as per WHO, the trauma care depends upon the phases of management. Previously, Hemlata ma'am has already described the triage and primary survey for our patients, but it goes beyond them. It's all about doing secondary survey and definitive care. So as far as thoracic trauma is concerned, it is almost 50% frequency which happens in any polytrauma patient. Almost 50% patient would have any form of trauma to his thorax, and then it is a real life-threatening condition. It causes 50% mortality in our patients, but still the solution is very simple. All our trauma patients requires only a simple chest tube placement to make them survive, to make their journey easier. For almost 15% of the patient, we require thoracotomy, but it's still a very difficult thing to do because the operative mortality in a trauma patient is almost 40 to 50%. So this is the study of AIMS, where I did my MCH. It's a 1 year data for patients, or polytrauma patients basically. And in almost 1500 patients, we could see that the thoracic region has injured in almost 50% of the patient. So what is mechanism and nature of injury which actually causes this thoracic trauma? It's basically road traffic crashes, which are the reason in 2/3 of patient, then fall from height, then assault, burn, and the nature of injury goes by blunt mechanism, penetrating, mixed mechanism, blast, and others. So all these mechanisms leads to injury because of deceleration, crush, and penetration. So what is the proposed mechanism of injury? How actually the tissue got teared after interaction of physical forces? So in theory, we got this implosion effect, inertia effect, and spalling effect. Spalling effect means in Hindi we could say that there is a pieces which got fallen from the wall. So these are very important, physical phenomenon which happens in a trauma patient, which leads to parenchymal organ injury. So after this, what are the consequences of thoracic trauma? It actually converges to hypoxia, hypovolemia, and mechanical ventilatory failure. And in delayed phases, we could see that there are secondary lung injury, pulmonary contusion, and eventually it would lead to sepsis, which causes prolonged stay in ICU. So what are the basic causes of hypoxia? If we see in terms of ATLS, the thoracic trauma compromises airway, breathing, and circulation part of any patient. And it has two components, pulmonary as well as cardiovascular components. So just to enumerate what are the causes of hypoxia, it's like tension pneumothorax, massive pneumothorax, which we basically know as a deadly dozen in thoracic trauma. So how this blunt injury causes hypoxia and reduced cardiac output? It produces myriad of symptoms like pneumothorax, pulmonary contusion, and myocardial dysfunction, which eventually converges to hypoxic injury and reduced cardiac output. Like similarly, blunt injury, the penetrating mechanism also causes, but the penetrating mechanism has a predominant tendency to produce tension pneumothorax in trauma patients. So what actually happens in terms of physics? It actually causes reduced supply of oxygen to tissues. So whenever we got a reduced supply to end organs in the terms of oxygen, the very late effect could be like AKI, liver dysfunction, and then VQ mismatch. So what is the philosophy of managing any polytrauma patient? So it all starts with primary survey, which was a trademark symbol of ATLS. And after primary survey, we actually need to know where our patient is stable or unstable. We are not interested whether our patient is having thoracic, vascular, or abdominal trauma. Actually, it is only unstable or stable patient. In cases of unstable patient, the patient requires damage control surgery, damage control orthopedics, damage control neurosurgery, and intervention radiological approaches. And if our patient is stable after primary survey, all you need to be further evaluation in the form of further diagnostic imaging and other endoscopic modalities. So suppose we are dealing with a thoracic trauma patient. On arrival, that patient actually requires expeditious, meticulous evaluation. It's not about evaluating the chest, it's always require evaluation of the neck, because if we are not going to examine the neck for a thoracic trauma patient, we are going to miss certain life-threatening injuries like tension pneumothorax. So this diagram actually represents what happens in a patient in which air is going to be collected extrapleurally, and when this air has found no escape, what it actually causes is shifting of the mediastinum on the opposite side. And at this point of time, the preload of the heart got decreased. So basically the problem lies with the breathing component of ABCD approach, but it produces a circulatory component. So in a tension pneumothorax patient, we got B part hampered as well as C part, which closely mimics the cardiac tamponade. But there are big difference between cardiac tamponade and tension pneumothorax. So for the postgraduate residents, or for that matter, and any MBBS student, this slide is very important. We are not supposed to miss pneumothorax. We have seen a lot of mortality happening around the world because of this tension pneumothorax. We are not going to miss these things. So how to read a chest X-ray? What is the systemic approach to read a trauma chest X-ray? It's always DRS ABCDE algorithm. You have to remember it by heart, and as our teacher says, Dr. Sahab, ABCDE. So this slide is very important for PGs because we have to follow a systematic approach. So one thing, I mean, if a trauma surgeon is going to recognize any abnormality in that chest X-ray, anesthesiologist and intensivist has to be there on the very same page. So what we are going to see on these slides, on the right side, this is, what is this? I mean, it's a tension pneumothorax or it's a pneumothorax? How many of you are saying that it's a tension pneumothorax? Pneumothorax? So tension pneumothorax is a clinical phenomenon. We are not going to subject our patient to chest X-ray, because if we subject our patient with a tension pneumothorax to chest X-ray, that patient belongs to mortuary only. So we have to diagnose this tension pneumothorax before subjecting him to a chest X-ray. So on the right hand side, we could easily see that there is a left-sided pneumothorax. And what about the left chest X-ray film? It could be pulmonary contusion, lung collapse, or hemothorax. So for trauma, it's always a massive hemothorax until unless proven otherwise. So initially, radiological depiction is very late. I mean, post-trauma, it's always hemothorax, because lung contusion development takes time and it translates into radiological finding. It's always took 72 hours at least to produce this picture for a lung contusion. So it is massive hemothorax. What about this X-ray? Any abnormality we could recognize because it's always given on the X-ray. It's already given. So left apical cap, widened mediastinum, deviated NG tube, and depressed left mainstem bronchus. What does it suggest? It actually suggests that there is traumatic aortic disruption. We are not going to miss. It's always suggestive of only, but it's not a definitive diagnosis for traumatic aortic disruption. We have 10 more signs for traumatic aortic dissection, which as a PG students, we are supposed to remember by heart. These are 10 signs which is being produced by aortic disruption. Suppose a patient got a real aortic dissection at the scene of injury. 80% patient would not make it to trauma center. So all those patients who actually arrive to trauma center having traumatic aortic disruption, it's not a full-blown injury. It's always intramural hematoma which produces this type of chest X-ray picture. So another primary survey adjunct is E-FAST. How we are going to recognize pneumothorax during an ultrasound, because since our UG days we have been told that air is a bad conductor for sound. So utilization of an ultrasound for detection of a pneumothorax, how does it possible for us? So there are important signs. That is actually produced by a normal lung. It's called a sliding lung sign. In cases of pneumothorax, this sliding lung got absent. And if you place this sliding lung on, if this sliding lung sign is absent on ultrasound, we are supposed to do a M-mode scan. In M-mode scan, it will produce a barcode sign. So if we are going to see a stratosphere sign or absence of sliding lung sign or barcode sign, that means this patient might have a pneumothorax basically. So which one modality is more sensitive? Is it chest X-ray or is it E-FAST? Is it ultrasound or is it chest X-ray? Which is more sensitive to detect a pneumothorax? How many of you say that it's a chest X-ray? Anyone to buy the concept that FAST is more sensitive to detect pneumothorax? In reality, this is ultrasound which is more sensitive, because we are going to miss the apical or anteriorly placed pneumothorax on AP view chest X-ray. So with utilization of our E-FAST in algorithm, we could actually recognize very small pneumothorax doing ultrasound only. So after primary survey, once we made our patient stabilized, we are going to proceed with secondary survey. It's all about look, listen and feel. We are supposed to examine our patient from head to toe, top to bottom, back to front. It's like simple clinical examination. It could actually produce the clue to potential life-threatening injuries. So another secondary survey evaluation is chest CT. After a patient is stabilized, what we are need to do. How many of you are going to do a chest CT in a polytrauma patient? And how many of you are going to do a chest abdominal CT in a polytrauma patient? Or does this patient requires a CT evaluation for whole of the torso? So the trauma center which are least developed in India, they just follow regional CT scanners for trauma patient. But as the saying goes that trauma respects no boundaries. If somebody got injured because of road traffic crash, he's not supposed to got injury just above the diaphragm. It's always torso in toto which got injured. So in a trauma patient, we never talk about doing a CT scan to the chest or CT scan to the abdomen. It's always CT to the torso. And which phase is required? There is no role of doing a non-contrast CT scan in trauma patient. It should always be done with the IV contrast only. There is no role of doing a CT with oral contrast. IV contrast portal venous phase is the diagnostic modality of choice as far as CT is concerned. So in this CT, we actually see the ground glass opacity on the right side, which suggests of pulmonary contusion. On the left side, the asterisk shows that this patient is having anteriorly placed pneumothorax. On the bottom of that CT, we could actually see there are a lot of lung lacerations. And what does this CT depicts? This is another phase of doing CT. This also shows that there is a pneumothorax with lung contusion and lacerations. And on the leftwards, we could see there is a hemothorax. So as I say, the trauma patient required trinity of evaluation. It's not always about clinical evaluation or radiological evaluation, as our intensivist friends or like anesthesiologist requires evaluation in the terms of biochemistry of that patient also. Like ABG, serum lactate and base deficit is quite important to recognize the severity of injury. So any trauma patient requires this trinity of evaluation. It's not only clinical, radiological. Biochemistry is also important, which actually suggests what phase of our trauma patient is and what is the actual trend of our patient. Is it dawning or is it emerging out of the trauma? So as far as management goes, so in trauma, primary survey is considered as a recognition part, as well as immediate life-threatening injuries had to be addressed for management. Like we are supposed to place a chest tube, and once our patient got stabilized, we require our anesthesia colleagues to place the proper analgesia to our thoracic trauma patient in the forms of intercostal block, epidural, or infusion. We need a lot of support from you people basically. So being a surgeon, it's a special topic like thoracotomy. Only 15% patient require thoracotomy for thoracic trauma. It actually depends in what phase we recognize the injury, how many days has passed since injury, and whether this patient requires urgent thoracotomy or is it electively placed thoracotomy. So as far as immediate thoracotomy is concerned, we actually never done ED thoracotomy. But in more evolved trauma center, if a patient received to us in a level 1 trauma center in a shock condition and there is no cardiac output, if we recognize that preservation of life is there are some signs of life, we are supposed to do an emergency department thoracotomy in that patient. And the intent is doing ED thoracotomy is to provide internal cardiac massage to cross clamp the aorta so that preservation of blood supply to vital organs could happen. So anesthesia consideration is very important. It's very unlikely to give anesthesia to an elective thoracotomy patient because most of the time we do not need a single lung ventilation. As a trauma surgeon, we need to do anterolateral thoracotomy, which can be very well done on both lungs actually inflated, because we have to recognize the ongoing air leak from the peripheral lung laceration. If we are if we do a DLT and we just isolated the lung, we could not recognize the smaller amount of bronchopleural fistula while doing surgery. It also depends. Actually, we need to balance whether we are going to produce more harm to our patient or we are going to subject him to more benefit. So timing of thoracotomy, as I said, that for immediate life-threatening condition, it should always be done in ED. And then for urgent thoracotomy, it could be done within the hours, like for massive hemothorax. So as saying goes, pray before surgery, but remember, God is not going to help you if you place a faulty incision in the thorax. So plan your incision very well. And the choice of incision depends upon overall clinical condition of the patient, whether we can reposition our patient on the OT table or not. So that is why trauma surgeons like to do an anterior lateral thoracotomy or median sternotomy or clamshell thoracotomy. So these are basic incisions which we are very fond of doing. Number one is anterior lateral thoracotomy and number two is median sternotomy. Choices depends. I mean, people there practicing in European country, they are very fond of doing anterior lateral thoracotomy. In South Africa, they like to do median sternotomy. But it also depends upon your skill acquisitions, like how much you have acquired your skill. So this is clamshell thoracotomy, and it actually provides exposure to bilateral lung fields as well as mediastinum. It took very less time. It only took 90 seconds to produce a clamshell because our patient is really crashing. It's a hard incision. Any idea what is this? This is actually pneumonectomy. When we have in a desperate situation, when a trauma surgeon tends to remove whole of the lung in toto. So we requires our anesthesia and intensivist colleagues very much for this situation because it is going to produce what? Pneumonectomy is a disease for a young adult, as we can say, because once we did a pneumonectomy, it is going to produce right-sided heart failure in our patient. So it's immediate right-sided heart which is going to be failed. For that situation, we require a wiser anesthesiologist because once we did a pneumonectomy, we are not going to survive our patient easily. So this is very new phenomenon which is going to happen in KGMC, surgical stabilization of rib fracture, because in last 10 years, there is a lot of involvement happened in the hardware like implant. So indications are emerging, and we had done just 3 cases at our center, surgical stabilization of rib fracture. So what is this? This benign looking picture depicts the cardiac stab. It's very cool that once you see this diagram in a textbook, you cannot understand what is actually happening inside the OT. So this is first cardiac stab which we done in AIMS. I mean, I was a senior resident. It's not like very benign condition. A lot of people are required. This patient actually we operated on the stretcher. Patient didn't given us time to shift him to OT. The surgery was done on a stretcher, and we make this patient actually survive. And it's actually a team effort. Like our anesthesia colleagues are very versed that cardiac stab is supposed to be intubated immediately in the ED, and we got no time to done and got scrubbed and got our dress ready. So you see, after repair, the heart is going to stand still. We provided internal cardiac massage, and lastly, you can see the effect of what a team can achieve.
Oh wow, very good, nice contraction. Okay, Dr. Santosh, sorry. Oh my God.
See, a better team can make any patient survive. So few words about traumatic aortic disruption. So a straightforward solution for traumatic aortic disruption is total endovascular repair, TEVAR. So this picture actually shows there is aortic dissection. This is what an intervention radiologist has to do for this patient. But sometimes With our best of efforts, we cannot make our patient survive. The last picture is actually autopsy finding. So this patient actually died after putting a lot of effort, and this autopsy was done by me only. So we just wanted to know that why this patient has died. Is it because of procedural failure? Is there some technical difficulty? So I find that in autopsy, the stent was at the very right place. But the thought process behind this slide is, even if we do lot of things to our patient, we cannot make them survive because we are not God. So I just wanted to end my talk with the quote, life is pleasant, death is peaceful. It's the thing in between which requires our kind help. So any question? I'm ready to answer any question. Yeah, ma'am.
Looking back, I think it was a wonderful talk. Very, very concise and very good. I think he's come from a different department and we need to ask him some questions.
Yes, please. No question means no attachment. Anyways, if you have any question creeping in your mind, you just contact me. I'm here in KGMC already. Thank you so much. Thank you. Thank you. Thank you so much.
Thank you, respected speakers, for your insightful words. Now I would like to request Dr. Monica Kohli ma'am to felicitate Dr. Hemlata ma'am. I would like to request Dr. MP Khan sir to felicitate Dr. Vaibhav Jaiswal sir. Now I would like to request Dr. Dipali ma'am to take over for the further proceedings.
Learning gives creativity. Creativity leads to thinking. Thinking provides knowledge, and knowledge makes you great. These are some pearls of wisdom to start our day, as stated by Dr. APJ Abdul Kalam. A very pleasant morning to all the respected speakers, eminent guests, esteemed faculty members, seniors, my colleagues, and my dear juniors. I, Dr. Dipali Chandra, would like to welcome you all on the CME and workshop on acute trauma care conducted in King George Medical University. I kindly request Professor Monica Kohli ma'am, Professor Zia Arshad sir, Dr. D. Himanshu sir, and Dr. Rajesh Raman sir to kindly come and get seated on the stage. I request Dr. Rati Prabha ma'am to kindly come on the dais and present a planter to Professor Monica Kohli ma'am as a token of gratitude. I kindly request Professor MP Khan sir to include us on the dais and please come and get seated on the dais. I request Radhi ma'am to please come and present the planter as token of gratitude. Sir. I request Dr. Satish Verma sir to kindly come and present a planter to Dr. D. Himanshu sir as a token of gratitude. I again request Dr. Satish Verma sir to please come and present a planter to Dr. Zia Arshad sir as a token of gratitude. I kindly request now Dr. Hemlata ma'am to please come and kindly present a planter as token of gratitude to Dr. Rajesh Raman sir. The function of education is to teach one to think intensively and to think critically. Intelligence plus character, that is the goal of true education. Trauma care is integral to the injury field because it is critical to decreasing the consequences of injury. Acute trauma care highlights the value and basic roles of an interprofessional team. It helps in evaluation and management of trauma patients in emergency department. We are highly privileged that we have got the opportunity to organize the CME and workshop on acute trauma care in KGMU. As a symbol of reverence to Ma Sharda, I request our dignitaries to please lighten up the lamp for a traditional lighting ceremony. A genuine leader is not a searcher of consensus, but a molder of consensus. With this quote, I would like to invite our disciplined, caring, and dedicated HOD ma'am, Professor Monica Kohli ma'am, to enlighten the gathering with our welcome speech.
You had to add the discipline, huh? A very warm good morning to all, and a warm good morning to our chief guest, medical superintendent of the university, Professor D. Himanshu, a good friend, and I think a big supporter of our department, anesthesia. Professor Parvez, who's a very, very close friend, and of course, part of the department. And where's Zia? Okay. And the organizing secretary, Professor Rajesh Raman, I think one of the very hardworking faculty of our department. And all the speakers, the delegates, and all the guests. I'm really honored to be here and giving you a warm welcome from the Department of Anesthesia, along with the Society of Trauma Intensive Care. So as we all know, the trauma is, I think, globally one of the largest reasons for mortality and morbidity. And I think a systematic evaluation of trauma in the acute phases is what is needed. And that is the USP of this CME also, that we need to have a quick and systematic evaluation of an acute trauma patient so that we can decrease the mortality and morbidity of the patient. So I hope these little gems which you are collecting over the talks and over the hands-on, which should be useful to you. I welcome you once again. Thank you.
Thank you, ma'am, for such enlightening words. Your words have always been encouraging us to work harder. I would request Professor MP Khan sir to kindly felicitate Professor Monica Kohli ma'am with a platter. I would like to request our diligent medical superintendent, Professor D. Himanshu sir, to bless us with their kind words.
Thank you. A warm good morning to you all on this cold morning, and I have to admit, when they said the program is going to start at 8:30 a.m., I got shivers in my at 8:30. It's so cold, and these days I think we don't even see light by 7:30. So I see that anesthesia department is actually now working on the international list, where we used to see outside that even where it used to be dark and the classes used to keep going on. Having said that, on a lighter vein, I have to thank the anesthesia department, ma'am, Monica ma'am, Pervez sir, and all for inviting me here. We all know that in medical profession, one of the things internally we know that we make a difference in acute diseases. In chronic diseases, there was a joke that doctors are like the snooze buttons, that we just keep on delaying things. But that happens in chronic disease. But when our real role comes in acute diseases, and trauma is something where we really can make a difference, where it's the difference between a proper life and death. The state of Uttar Pradesh, as we know from the data, has one of the highest number of road traffic accidents. And I see Dr. Samir Mishra already preparing his slides. And I'm sure he is going to tell you a lot of things about that. Recently, we had a lot of discussions even with the UP government, and the UP government has been trying to conduct trainings to how we can actually decrease the mortality by the initial hours of acute care. So looking at that, this CME becomes very important, and I am happy that the anesthesia department as such has always been doing a lot of programs in this area, and I congratulate Dr. Raman for conducting this. And I see a pretty decent amount of residents out here. I'm sure with all the knowledge that you get from here, you might make changes in your practices, which down the line would lead to the changes that we are expecting. With these words, I would like to hand over the mic to you. Thank you for calling me here again. Thank you.
Thank you, sir, for your kind words. I now request Professor MP Khan, sir, to please come on the dais and say some wise words, please.
Actually, the team for the next session is already here. So much has been spoken. It is better that we move the way forward. Okay.
Sir, but we would like to felicitate our respected teachers, our seniors, with a memento. Sir, I would request Dr. Ravi Prakash sir to please come on the stage and felicitate Dr. D. Himanshu sir with a memento.
thankful यही सब तक खत्म करो.
So no, are these geotagged?
This is good actually, you know.
I would now request Dr. Karan Kaushik sir to please come on the stage and felicitate Professor Monica Kohli ma'am with the memento. I would now request Dr. Sarita Singh ma'am to please come on the stage and kindly present a memento to Professor Sandeep Hansen. I would now request Dr. Vinod Srivastava sir to please come on the stage and felicitate our Professor Zia Arshad sir with the memento. I would now humbly request Dr. Brijesh Singh sir to please come on the stage and felicitate Dr. Rajesh Roman sir with the memento. For my part, I am very content and thankful to our guest. Gratitude makes sense for our past, brings peace for today, and creates a vision for tomorrow. With the above words, I would like to get our organizing chairpersons a felicitation. So I would now request Dr. Dinesh Singh sir to please felicitate our co-organizing chairperson, Professor Zia Arshad sir. At last, I would like to bring the ceremony to an end by calling upon our enthusiastic and hardworking co-organizing secretary for the very last time, Dr. Rajesh Roman sir, to deliver the vote of thanks. Thank you so much.
Very good morning to you. First, I would like to thank the dignitaries and the delegates and the speakers who have blessed the CME with their presence and the knowledge. I thank Monica Kohli ma'am and the organizing team, especially G.R. sir, Dr. Vinod, Dr. Ravi, Dr. Rati, Brijesh, and all those who have helped in conducting this CME. My special thanks again to the delegates who have made this CME possible. I really hope that you learn a lot from the CME and the workshop. Thank you.
Morning, everyone. Now, moving on to our second session, I would like to request our chairpersons, Professor Dr. Dinesh Singh sir, Department of Anesthesiology and Critical Care, Dr. Sarita Singh ma'am, Professor, Department of Anesthesiology and Critical Care, and Dr. Satish Sharma sir, Professor, Department of Anesthesiology and Critical Care, to introduce the speakers, please.
ये abdominal pelvic trauma.
Hello, good morning to all. We start the first session and the speaker is Dr. Shamir Misra. He is well known to all. He is professor in trauma surgery, KGMU, Lucknow. I will invite Dr. Samir to start his talk.
Thank you, Professor Dinesh and Sarita ma'am. It is indeed a matter of pride and honor to be addressing in front of my seniors, whom I have worked with a lot of times in emergency as well as in elective surgical procedures. So, first of all, heartfelt thanks to Dr. Zia, who has been a wonderful friend and has invited me to speak on something which is quite commonly seen in our trauma setup, which is abdominal and pelvic trauma. I've been bothering Zia for a lot of times in odd hours to take transfer of our patients who have been suffering from abdominal or pelvic trauma. And he has never let me down. Always with a smile, कि boss 15 मिनट में भेज दीजिए, अभी भेज दीजिए या थोड़ी देर रुक जाइए. So this is something which I would like to acknowledge here, that all my presentation slides are actually made by my JR3s, and one of them, Kangcha, is sitting here. And it actually gives them an opportunity to actually interact with the consultants who would like to share the stage on certain sensitive topics. So when we talk about the abdominal and pelvic trauma, there are certain things or certain datas which people would like to share, that what is the prevalence, what percentage of abdominal trauma patients do you deal with? And we have not given any data here, because let me remind you that every other patient in trauma center is somehow suffering from some kind of abdominal pelvic problem if was involved in any kind of traumatic incidents. So the prevalence, if we take the data, is approximately 40-50%, but in a tertiary care center, level 1 trauma center, which we in KGMU pose ourselves to be, the prevalence is quite high in the sense that we get patients from all over the state as well as from the neighboring states as well. As far as the pelvic fractures are concerned, our orthopedic friends usually try to find out ways that is the patient having mechanical instability and they would like to fix the problem. But if we talk about the critical care people or our friends in ICU, their concern is hemodynamic instability of the patients. So what we need to know is unrecognized pelvic and abdominal injuries are important cause of unexplained death in all trauma victims. Assessment of patients is many times very difficult when the patients are of polytrauma and there is a component of head injury. Patients during Holi and during festival seasons are intoxicated and they tend to give very false signs or symptoms in regard to assessment. Significant blood loss caused in the abdominal cavity is many times oblivious and can actually take the patient or dip the patient suddenly. So when we talk about the areas of abdomen, we have actually started coining a different term. We do not call abdominal trauma nowadays, we call it a torso trauma, in which a part of chest and of course pelvis, including retroperitoneum, is involved. As you can see in the picture, the abdomen actually houses lower part of the chest, in which, of course, the thoracic cavity is involved. There is component of two major structures in the abdominal cavity. One is the hollow viscous, which is the bowel, most commonly injured, and solid viscera, which is, of course, the spleen or liver, or in the retroperitoneum, it can be the kidney, which is many times involved in traumatic events. When we talk about the mechanism, we usually divide it into two groups. One is the blunt, the other one is the penetrating injury, and it can be a combination of both in many trauma victims. We have seen a lot of cases of road traffic accidents, and a lot of patients who come to us are of blunt injury abdomen. It can be direct blow, it can be shearing force, as my friend Weber must have talked. It can be a deceleration injury, or it can be an injury that is communicated, which is not very obvious. People say that my airbag was deployed when I was hit in the car, but it does not actually make you less prone for abdominal injuries in a road traffic incidents. When we talk about the penetrating traumas, stab and impalement injuries, laceration and tear of the tissues, quite commonly seen. Both these photographs are of our trauma center, and the later one, in which an impaled angle was inside a patient. The challenge for the anesthesia team was a lateral position of the patient, and it was a difficult intubation for the anesthesia team. Of course, the expertise of the team was available with us, and we were able to save the patient. When we talk about the penetrating trauma, most of the challenges what we face is firearm injuries. And even the firearm injuries, the biggest challenge is we certainly sometimes do not realize that the traverse or the path of the bullet or the pellets cannot be actually predicted. There are incidences when we were hunting for the bullet in the abdomen after a firearm injury. We could not find it, and after 2 days, the patient actually passed the bullet in his feces. So there are things or the challenges that we have to predict when we talk about the firearm injuries. When the patient arrives in the ED, the primary survey in concern to airway, breathing, and circulation are dealt with. Unless the patient is stabilized, we do not actually transfer the patient or take the patient to the secondary survey part. But the adjuncts that can be very, very oftenly used during the primary survey is X-ray chest and X-ray pelvis, and of course EFAST, which gives us a good idea that the abdominal cavity is actually filled with something, free fluid or not. If there is free fluid in the abdominal cavity in all trauma incidences, we actually presume that this free fluid is actually blood, and the patient might land up in hemorrhagic shock. When we were talking about the thoracic trauma, there were two challenges that we faced. One was hypoxia, the other one was shock. When we talk about the abdominal trauma, the major concern is shock in immediate stages of traumatic event. And as the time passes and the surgical or non-surgical modalities take their time, The second part that concerns all the critical care physicians and intensive care personnel as well as the surgeons is the septic focus that can actually develop in the abdominal cavity after a procedure or without a procedure. So what we use as adjuncts in primary survey is of course vital signs, pulse oximetry, and the major thing that actually involves the critical care or the anesthesia people is the arterial blood gases. Now these are the indicators that gives you a good clue what type of resuscitative measures you should advocate and how fast a person or a patient should be resuscitated. Chest x-rays as well as pelvic x-rays give a good idea to the surgeons that what the cause of shock might be. FAST gives a good clue that the free fluid in the abdominal cavity, which can of course be blood, is in the quantified manner how much and what type of operative management or non-operative management can be advocated for these particular victims. So when we talk about the surgeons, they think about shock in view to turn on their OT lights. That means take the patient or roll the patient for a surgical procedure. While when we talk about the critical care personnel or the intensivist, they think of shock in terms of sepsis, hemodynamic stability and hemodynamics, output or end organ perfusion, cardiac anomalies that can take place, kinematics, both of pharmaceutical drugs, as well as the kinetics of the patient. That means the patient might go from ED to OR or might land up from ED directly to an ICU. When we talk about the time of death, all the trauma victims who die early or late usually die because of hemorrhagic shock. Now, these are the victims who account for more than approximately 50% who die within 24 hours, and these are the patients who actually are the victims of hemorrhagic shock. And this is the time when our anesthetist friends would like the surgeon to go in early and get out of the abdomen as early as possible without wasting much time and without causing even more blood loss. But if the patient survives the primary survey and actually comes out of the ED to be landed up in an ICU or a OT or a ward, there is good amount of time that we can get to take an ample history. And this kind of history actually can predict the outcome of the patient and of course give time to the critical care personnel as well as the surgeons to plan the future course of these particular patients. If we talk about motor vehicle crash, there can be good clues that how much the intrusion of the passenger seat took place, what was the time of extrication, what type of injuries were suspected at the site. When we talk about the falls, how much height, what kind of fall, where the fall took place, and if we talk about the penetrating injuries, of course, what type of impalement object, firearm used, and so on. So secondary survey in HDU or ICU actually gives good time to take ample history, which is A for allergy, M for medication, past meal, pregnancy, last meal, events. And most important for all the surgeons is of course the events. They're not bothered about allergies or medication. But as a critical care person, you have to actually take into account all these things. Coming to the abdomen, there is good chance if you look at the abdomen itself is going to tell you that is it a surgical abdomen or you can wait. So look, listen and feel. Examine for distension, bruising, skin wounds, marks, tenderness. Use e-fast as early as possible to give you more clues. There are certain pitfalls when we talk about the elderly population, distracting injuries, altered mental state, which can actually alter your decision or mask the signs or symptoms of an abdominal injury. It is mandatory to examine the perineum. There are so many instances when the surgeons or the ED team actually has missed the perineal injuries, and it was actually found in secondary survey, which is not a good thing. That means we have not examined the patient nicely. So, FAST gives you a good clue, gives a window of a view in the cardiac field as well. An e-fast can actually also detect hemo or pneumothorax. A fast on the abdominal cavity can give good clue that free fluid is inside the peritoneal cavity, and there is a good chance that you can predict injuries, liver or kidney or a pelvic injury by using e-fast. Missed injuries, very often we have seen that senior clinicians have missed injuries, and it was brought to the notice of the clinician in charge or a ICU personnel by a very junior fellow or even a paramedical staff. Sir, uske bed pe kuch gandagi phaili hui hai. And this is a very common thing that we see perineal injuries were missed. So missed injuries are to be avoided. So if the patient survives the primary survey, it is a good idea during the secondary survey to examine the patient from head to toe and from front to back. When we talk about the damage control resuscitation, the two components of permissive hypotension and hemostatic resuscitation are done by the critical care personnel. And when we talk about the damage control surgery, this is the only opportunity given to the surgeon, which goes inside, comes out as early as possible, doing bare minimum so that the life can be sustained. Previously, the patient used to come to ER, go to OR, and go to mortuary. But with damage control surgical concept and damage control resuscitated measures, the patient goes to ER, goes to OR, comes back to an ICU, stays in the ICU for a while, actually develops better physiological reserve, goes to the OR again for a definitive procedure, comes back to the ICU and survives. So performing a definitive surgical procedure after trauma events when the physiology of patient is compromised is never advisable. It is always a good idea that we take the patient, do the minimum, and give an opportunity to the patient to develop the physiological reserve and correct the physiology in an ICU. So indications for DCS are many. Patient is dipping, you don't have time, go for damage control surgery. Do not wait for or do not take time out to do a definitive procedure, but just give an opportunity to the patient to do a physiological correction. So the timeline is again quite jumbled up, but don't bother to look at the chart. Go to the OR, do the minimum, get out, take the patient to an ICU, build the physiology of the patient, come back to our OR, do a definitive measure, and take the patient again to an ICU. This gives a good opportunity to these trauma victims who are suffering from polytrauma or major abdominopelvic trauma to or for survival. Detailed radiology, of course, the term has changed now. It is not CT abdomen, it is CT torso. A detailed radiological maneuver can only be performed in patients who are stable, and they give an opportunity to the ICU personnel or the surgeons to actually do a CT scan. Even contrast studies can be done in a stable patient. Coming to the management, what are the indications of laparotomy? As the photograph is quite obvious, this is the last indication. I think you recognize both. So, an anesthetist denying a laparotomy and the surgeon on the knees requesting a laparotomy. But this is the last indication that can happen. The rest of the indication, of course, are given in the checkerboard chart. Any condition in which the surgeon agrees to open up the abdomen is an indication for laparotomy. The anesthetist can deny only on one condition. That means the patient is not giving an opportunity of physiological reserve to the surgeon to perform a surgery. That means a surgery should be performed, not an autopsy. So it is a good handshake between a surgeon and an anesthetist, which can actually give an indication for laparotomy. So again, a checkerboard, a very confusing checkerboard. Don't worry, this is for the surgeons to understand. Even more confused or confusing checkerboards. But these charts have only been put up here to just give you an idea. The surgeons usually are quite educated, well-read people. They follow so many protocols. It can be a splenic injury protocol, a liver injury protocol, or a renal injury protocol and whatnot. And if 2 or more organs are damaged, these protocols actually get jumbled up in the heads of the surgeons. So it is again not advisable to look at the protocols, but do what is right for the patient on the OR table. Of course, in consultation with the anesthetist friends. Closing the abdomen in damage control surgery, of course, is not a very good idea. So what we do is we temporarily close the abdomen because we have to go in again. And of course, it avoids the compartment syndrome if there is a lot of septic foci and there are chances to have a compartment syndrome. So it is a good idea not to close the abdomen, give an opportunity for the physiological correction and come back again. When we talk about the pelvic trauma, of course, orthopedicians can be involved, Very rare to find orthopedicians in the OR of a trauma team. So if you can find an orthopedician, get him here and get the stability of pelvis done. Because a stable pelvis is again going to give you a good chance that your hemostatic control is good and the chances of getting out of the shock or the cardiac problem is more. Special considerations, of course, elderly, they mask so many things. They mask their symptoms, their signs, they are on certain drugs, so they mask the effects of shock. So keep in mind an elderly person involved in a trauma event, that there can be so many pitfalls when dealing with them. Same thing for pediatric patients. There is a lot of variation when we talk about the vital signs. Pediatric airway is a challenging airway, and there are people like Professor Sarita ma'am, who I've seen her working many times in pediatric surgery OT, and she was an expert in putting in an airway. Vascular access again is a challenge. Fluid resuscitation, drug calculation, and this is for all of you to do. It is not a surgeon's job. So, critical care considerations. again, your baby. Three things: coagulopathy, hypothermia, and metabolic acidosis have to be dealt, and there are good chances that by managing all three, there are good chances that you would be not able to juggle all three balls. When we talk about the first head phenomena, these are for the surgeons to deal, while the second head phenomena for late deaths, the critical care personnel are more concerned. When we talk about the triad of death, very commonly seen in ICUs, clotting problems, coagulopathies, hypothermia, and acidosis have to be dealt with. The third triangle or the diamond that has been made now is hypocalcemia. So dealing with electrolytes, dealing with calcium, dealing with coagulopathy is all your baby. So using a TEG-like thing is important at this juncture, which is quite commonly available at in your ICUs. So bleeding control, of course, job of the surgeon, but coagulation correction, job of a critical care person. Massive transfusion protocols, let me tell you, in my from my residency days to my professorship even, I was able to trigger massive transfusion protocols only 5 or 6 times. That too, only 3 times successfully. It is very difficult to trigger it and even more difficult to manage it. So when we talk about the initial resuscitation, which is of course a team effort, in which macro circulation is targeted, while if we talk about the micro circulation or endpoint circulation, it is the role of the critical care people or an ICU intensivist who can actually deal with it better. So passion, teamwork, mutual understanding and respect is actually an amalgamation of all 4 which can help to end the pleth of a trauma victim, and actually it can help in the fight for survival. What we have seen is the surgeons usually are very happy, just under thank you, to take out an impaled rod, and they take always the smile, and they're very happy with the successful surgical procedures. But the critical care personnel smile only when their monitors and their patients show better results. So good leadership, good training, and a team effort, hard work actually pays well in all the trauma scenarios. Thank you. Thank you.
Now I would like to request Dr. Dinesh Singh sir to kindly facilitate Dr. Samir Mishra sir.
Hello. Thank you, Samir sir, for nice presentation. Now, I would like to invite my colleague, Dr. Kaushik. He will talk on shock in trauma victims.
Good morning, sir, and good morning, everyone. First of all, a very warm good morning to my respected teachers and all dear residents in this chilly winter morning. First of all, I will like to know, apart from anesthesia residents, do we have residents from other department also? Okay, that's great, that's great. So, I'm fortunate enough to deal with a very interesting topic. So, let me see all the budding critical care specialists, anesthesiologists, physicians, and casualty officers. Let me see the young guns, how keenly you monitor or observe your patient. Okay. So So whenever you expect any patient coming to you in a casualty, trauma, ICU, with a history of trauma, what is the first sign that the patient is in a impending shock? Please, anyone. Just the first sign. Okay, let me make it more simple to you. Before the hemodynamic compromise kicks in, that means अभी बीपी हार्ट रेट सब स्टेबल है, पेशेंट फुल जीसीएस में है, आपके पास आया है. फॉर एग्जांपल, आप कैजुअलिटी में पोस्टेड हो और आपके पास 3-4 लोग अपने एक फ्रेंड को लेके आते हैं, डॉक्टर साहब बाइक से नीचे गिर गया था. आपने बोला सिस्टर को या अपने फर्स्ट ईयर को बीपी लो, नॉर्मल है, हार्ट रेट 100 है, वापस भेज दोगे पेशेंट को. व्हाट इज द फर्स्ट साइन एक्चुअली? एनीवन प्लीज. Sorry, louder. Okay, now after this slide, I think you won't be forgetting the first sign. Anyone still wants to try? The first sign, जो लोग मेरे साथ होते हैं पोस्टेड रहते हैं स्पेसिफिकली रीजनल एनेस्थीसिया में, मैं बहुत परेशान करता हूँ इस साइन के लिए. Not yet. Vitals are stable. Everything is perfectly stable. This is the first sign. Full GCS. Patient is full GCS. Absolutely fine. But mark my words, अभी full GCS है, heart rate BP normal है, 4 घंटे के अंदर non-salvageable हो जाएगा. That's not a first sign. Sign is what? You're getting me? Sign का मतलब है आप patient को examine करते हो, है ना? Sorry? Agitation, no. Patient absolutely calm, composed, sitting. डॉक्टर साहब गुड मॉर्निंग, कैसे हैं, ऐसे बात कर रहा है आपसे. हिस्ट्री ऑफ ट्रॉमा के साथ आया है अभी. और लेट मी टेल यू फ्रैंकली, 5-6 hours नो इंटरवेंशन, यू माइट लूज दैट पेशेंट. फर्स्ट साइन, प्लीज. Okay, so I won't waste much of the time. So we will begin with the etiology that will give you the first sign, and please remember for life. Trauma. Okay, trauma anywhere, any place leads to some abnormality in the cardiovascular system. And Almighty has gifted with such a beautiful machine that it compensates anything. Okay, and that cardiovascular system, any abnormality in it, puts the body in an imbalance between demand and supply. At a tissue level, cellular level, the supply of oxygen with the hemoglobin and actual requirement of that oxygen at the cellular level, this demand supply mismatch sets in because there is some hidden bleeding somewhere and patient is not yet symptomatic. Patient has just started to have that bleeding. Okay, patient is not yet symptomatic, bleeding शुरू हुआ है अभी, पेशेंट ने कॉम्पनसेट कर लिया है. That demand supply mismatch has been compensated by the patient. But as you all said me, that you are waiting for the tachycardia, hypotension, cold limbs, then what will be happening? Because of the reduced ATPs at the cellular level, later on there will be a metabolic failure, a cell death, and later MODS, multiple organ dysfunction. So never ever miss the first sign. What's that? At the tissue level, there is a demand supply mismatch. Fine. And our body is kicking in the anaerobic metabolism of glycolysis to produce ATPs to satisfy the demands of cell. Heart may be, brain may be, kidney may be, and most importantly, in your the biggest organ, skin. है ना, स्किन में आपके एटीपीज बनाने के लिए ग्लाइकोलिसिस हैज शिफ्टेड टू एनारोबिक. सो लैक्टिक एसिड्स भर रही हैं. सबका एबीजी तो करोगे नहीं आप, है ना? एंड दिस लैक्टिक एसिडोसिस इज हिटिंग द मेटाबॉलिक एसिडोसिस. ओके, बट द पेशेंट इज चिल, calm, composed, greeting you because he is compensating it. How? Now tell me. Good. This is your first sign. Respiratory rate. When I'm telling the respiratory rate, I'm telling it the normal respiratory rate is 12 to 14. Okay. When it crosses 14 to 20, you should be apprehensive. There is something kicking in. When it is beyond 30, that is actually the time when you see the tachycardia. Okay. So respiratory rate increase is the first and most primitive sign which you missed. कभी भी पेशेंट को देखना, चाहे ओटी में, जैसे सर ने बताया सर्जरी कर रहे हैं, पेशेंट स्पाइनल में चल रहा है, थोड़ी बहुत ब्लीडिंग हो रही है, मालूम नहीं पड़ रहा है, ट्राई करना रेस्पिरेटरी रेट से. So now coming to the my other discussion, the next slide. First of all, रेस्पिरेटरी रेट ने से आपने देख लिया कि पेशेंट को कुछ कॉम्प्रोमाइज होने वाला है. ओके फाइन, बट बिफोर एक्चुअली the patient lands up in trouble, is there any investigation that can prove it? To diagnose before the actual hemodynamic compromise sets in. Question number 1. And what is the simplest monitor to diagnose? So, anyone? Simplest investigation. Good. But वो इसलिए मैंने बताया आपको, लैक्टेट्स को छोड़ देते हैं, ठीक है? लैक्टेट्स को हटा देते हैं. लैक्टेट्स अभी नॉर्मल है, फॉर एग्जांपल 1.9 है, नॉर्मल हो गया किसी को. देयर इज वन मोर थिंग दैट विल टेल यू एट वेरी मोमेंट जब पेशेंट का रेस्पिरेटरी रेट 15 या 16 का होगा, दैट द पेशेंट इज गोइंग टू लैंड अप इन शॉक वेरी सूनर इफ यू डोंट एड्रेस इट. Somewhere closer. Anything in ABG? Okay, then I will be having fun in discussing it. So we'll wait for the first question. Second is, what is the simplest monitor when the patient comes to you? Sorry? Saturation, good. Pulse oximeter, good. But how does the pulse oximeter will tell you that there is a chance of hemodynamic compromise? Anyone? That's actually a star question. I am sure only few of you must be knowing it. Pulse pressure variation, not only the keen eyes will judge. Okay, something that is not simple monitoring. आपको बहुत ध्यान से देखना रहेगा. I am talking very simple monitor. बेटा उसमें क्या दिखता है? Very simple, very simple. Okay, then I am again going to have fun in this. So, for this, we have to study the physiology. Now, we are having blood loss. They are at stages. पहले तकरीबन 150 ml, फिर 750 ml, फिर 1200, 2000 stages. आपकी एक्सपर्टाइज उसमें है जब आप 100 से 200 ml के ब्लड लॉस में ही कैच कर लो. Okay, so we are dealing with that. So, whenever there is a blood loss, okay, then your physiology, sympathetic stimulus, what it does, vasoconstriction at cutaneous and peripheries. बताया किसी ने cold calm skin है ना, vasoconstriction कराते हैं सारा blood divert करने को इन 3 organs के पास. Fine. अब क्या होता है, जब आपका vasoconstriction होगा तो there will be vascular resistance, it will increase. And vascular resistance, it signifies diastolic blood pressure. So it will lead to raised diastolic blood pressure. Clear to everyone? And when I say raised diastolic pulse pressure, that will give us narrow pulse pressure. Systolic pulse pressure तो उतना ही है, लेकिन vasoconstriction करा रही है बॉडी हमारी to push the blood to kidney, heart and good. So अभी हमारा पल्स प्रेशर कम हो जाता है, ठीक है? So अभी any answer to this question? Okay, fine. Then hit the other question first. Whenever there is blood volume loss because of blood loss, what will be having? Will be having a low cardiac output. Yes, that is true, but not the exact answer. And there will be some compensatory changes to manage manage the decreased cardiac output जो आप लोगों ने बताया, that is tachycardia. We will discuss. Every age has a separate criteria for tachycardia. So volume of blood loss, compensatory tachycardia, right? But can we find out early? There is volume loss, there is tachycardia, BP is normal. Right now, BP is normal. Patient conscious, alert. Diastolic blood pressure बढ़ा हुआ है, tachycardia है. Can you guess? Okay, fine. Have you heard of SpO2 or ScVO2? In very short, we'll discuss later. Whenever you have such patient, किसी ने ABG बोला, ABG ना करा के उसका VBG कराएंगे, ठीक है? और VBG से हम पता लगा लेंगे कि आगे की कहानी क्या होने वाली है. We'll discuss it later. Coming back to the second question, what is the simplest monitor to diagnose? Pulse oximeter, perfusion index. हर पल्स ऑक्सीमीटर में कोविड के बाद तो जो 1500 के 1000 के आते हैं पल्स ऑक्स उंगली पे लगाने वाले, उसमें भी पीआई लिखा रहता है. कभी ध्यान दिया वो पीआई होता क्या है? That is actually a very sensitive monitor. Just putting on the pulse ox, 90% PI लिखा रहेगा साथ में, and you will get that. We'll see how. But why are we doing all this exercise? What's the fun of diagnosing all these things too early? This is one of the three organs: brain, kidney, heart. Heart बेइज्जती सह लेता है थोड़ा बहुत. ब्रेन के लिए सर आई गए हैं, we will discuss. किडनी एक ऐसी ऑर्गन है जो बहुत सेंसिटिव है, हल्की सी भी खुरापात बर्दाश्त नहीं करती है, फटाफट से भाग जाती है एक ही आई में, तो हम इससे बहुत डरते हैं. ओके, we are afraid actually of the kidney. That's why we have to think faster, we have to act faster than the disease. So as I told you, stages of blood loss. Okay, and stage 1 we have 750 ml, 1500 ml, 200 and more than 200. The point to look out is the tachypnea. The slightest, even less than 750 ml of blood loss, 100 ml, 200, 250, 300, 700, you will have a resting respiratory rate 14 to 20. That is less than 14 is normal. Okay. And the second catch point is renal involvement. Whenever there is more than 1000 ml blood loss, आपकी kidneys बुरा मानने वाली हैं, and you can get stuck as an anesthesiologist, as an intensivist or a physician. So coming to the next slide, tachycardia. As I told you, it's different for every age. In fact, any answer? कितने heart rate से ज़्यादा tachycardia बोलोगे? Good. Preschool. Good. Puberty तक, till puberty. Good. And adults, everybody, 100. So I told you कि VBG कराने के लिए, right? This is mixed or central venous oximetry. This is a new concept routinely used in the ICUs and the casualties. What it says, there is a recent survival benefit study of the trauma that says whenever I will make it simple. That's a huge discussion difference between ScVO2 and SvO2. SvO2 is mixed venous oximetry. You get a VBG from any vein, जो उस पे S saturation लिखा होगा वो SvO2 है. ScVO2 is specifically from the upper subclavian. Mixed venous is upper and lower both. But as a layman for right now, the VBG having the SO2 in that, we will consider it as SvO2. And 70% plus is normal. आपका कराएंगे 70 आएगा, 72 आएगा, 68 भी आ सकता है. लेकिन अगर 65 से कम आ रहा है, any patient 65 से कम आ रहा है, there is some pathology kicking. Patient having history of trauma, patient having this VBG having less than 65% SvO2, you have to hit hard, get X-ray, get fast. The patient is bleeding. Now pulse oximeter, right? This small encircled in this red line is perfusion index. This is a normal perfusion index, right? Saturation, heart rate, perfusion index. This is a normal perfusion index. Basically, the pulse pressure is not calculated by the pulse ox. The pulse ox finds it easy to check the perfusion index. आपने फिंगर पे प्रोब लगाया है, फिंगर में ब्लड सप्लाई कितनी अच्छी है वो आपको परफ्यूजन इंडेक्स से दिखाई देगा. पेशेंट वैसोप्लेजिक शॉक में है, हाई आउटपुट फेलियर में है, यही परफ्यूजन इंडेक्स आपको देगा फाइंडिंग ऑफ 20-25. और वी आर इंटरेस्टेड इन अ पेशेंट ऑफ शॉक, ट्रॉमा, आरटीए, उसको आपने पल्स ऑक्स लगाया. देयर इज अ कंफाउंडिंग फैक्टर दैट इज दीज विंटर्स. अभी हमें भी लगाएंगे तो हो सकता है ठंड में हाथ में ऐसा ही लगे, है ना? बट इफ अ पेशेंट फ्रॉम ट्रॉमा कमिंग टू यू, you put a pulse ox, you will find this 0.72 is the perfusion index, right? Tachycardia had set in. Compare it. This is an advanced monitor, basically can compare two pulse ox. So above 80 is the saturation, which is false because of the vasoconstriction. 99 is the normal, just for the comparison basis. The above 0.33 is the perfusion index. Two patients sitting calmly with good BP, talking to you, but one is having 0.33, other is having 2.1. Any figure less than 1, you should be cautious. Any figure less than 0.5, impending shock, if winters are excluded. So, I hope मैं चार्ट नहीं रहा हूँ सबको, तो will come with the cardiac shock in the trauma. That is very dry topic, but I will try my level best. So as I told you, less oxygen, lactic acidosis, anaerobic metabolism, decreased ATP synthesis, and because the heart needs ATPs to contract, first of all the relaxation will go because that's also need the ATPs, and then the contraction will go. Okay. So patient will land up in generalized hypokinesia with decreased ejection fraction and mostly tachyarrhythmias. This is the heart getting it. When the lactic acidosis later on, it causes vasoplegia, and whenever the pH is less than 7.2, no matter how much NORAD, calcium, vasopressin you give, it won't respond. So vasoplegia means less diastolic blood pressure, and less diastolic pulse pressure means less coronary perfusion pressure, because diastolic blood pressure minus LVEDP is your coronary perfusion pressure. That means, in short, we have reduced coronary blood flow. And reduced coronary blood flow, why knowing it is important is, in shock, if any patient, 65-year-old, diabetic, will come to you, और आपने उसको सेंस नहीं किया रेस्पिरेटरी रेट से, he might be having a subclinical CAD that is asymptomatic, and with the shock, with the reduced flow, his CAD will land up in myocardial infarction. And all those obese, heavy patients, heavy built people like me who have a bit of left ventricle hypertrophy to supply blood to the big bodies, they might have ST depressions, and rest will have a stress response in the ECG. So this generalized hypokinesia will lead to pre-renal failure to AKI, and then AKI to hyperkalemia, and then all these things, just a take-home message, will cause the trauma patient will be highly prone to ventricular fibrillation. So take-home message is, your trauma patient, tachyarrhythmias, prone to VF, and you have to diagnose early, because if you don't diagnose early, there will be some बूढ़े बाबा जी जो CAD लेके बैठे हुए हैं, बस साइन आपका कराना चाह रहे हैं अपने prognosis पे. So the shocks encountered here is most commonly hemorrhagic, cardiogenic, if the trauma is on the chest, tamponade, neurogenic, spinal shock, and tension pneumothorax and sepsis. And the most important part is history and assessment, and anticipate the shock and the site of bleed. Look for the key points, and the key point is when the patient is still holding the BP, doesn't appear pale, full GCS and oriented, you hit at that particular time. Anticipate and diagnosing early and treat is the key. It might save a precious life. What are the key points? Key points. Earliest sign, please Respiratory rate, good. Early signs, tachycardia and increased diastolic blood pressure. Down pulse pressure, you can sense by the pulse ox. Earliest, simplest monitor, pulse ox, perfusion index, you got to know. Earliest blood investigation, SpO2, right, you know. And just they are few minutes in advance to what she actually told, cold peripheries, okay? So with all these things, before the patient is having cold peripheries, you can catch it beforehand. So take home message, trauma patient, cold peripheries, tachypneic, fast pulse, despite any BP, any GCS, any SpO2, is in shock until proven otherwise. Fine. So this was the basis of the discussion. We'll go fast with the management. You people will manage now. Does it require surgery? Yes, time is life. The bleeder has to be addressed. If a patient is unstable, there is a concealed arterial bleed, injury is in the major vessel, major bone fracture, visceral injury, you need an early surgery. Sooner it gets addressed with the surgeon, better is the prognosis. How to locate the bleeding? Yes, physical examination, chest x-ray, pelvic x-ray. And diagnostic peritoneal lavage for the peritoneum is 99% sensitive but invasive. Gold standard is CT scan. Anywhere it can detect less than 100 or 100 ml of blood. But it challenges are patient को transport करना पड़ेगा. Patient का BP कम है, unstable है, and there will be a lot of delay. तो हमें क्या करना चाहिए? Any faster tool you have? What to do then? Something quicker we can do? Sorry? Louder, please. We are living in the era of point of care immediate testing. Your steps are going to get replaced by it. Okay? Era of ultrasound. So Dr. Neil Kamal will be taking it in detail. So this is focused assessment with sonography for trauma, fast. We have protocols, 96% sensitive and 100% sensitive in a patient with hypotension in trauma. And only 5 minutes, less than 5 minutes you can diagnose. And pathway to the fastest surgical intervention and prognosis is USG. What we see pericardium, we see 3 spaces in the peritoneal cavity, and then we see the anterior thoracic, and there is terms known as EFAST that includes the left and right anterior hemithoraces also. That's the purely clinical part. We will be doing hands-on in that. Our goals are of the treatment: stop the bleeding, push the volume, and assess the response. 3 things. Immediately, whatever comes first, volume push karo, bleeding stop karo, or assess karo response ko. तो bleeding को stop करने के लिए surgery the priority, direct pressure to purchase the time. If there is fracture, you have to address it. Last resort, angioembolization, but patient तब तक शायद रुके नहीं आपके पास. Plan of action, ABC management protocol, and then immediately oxygen support. Remember, we are lacking in the oxygen delivery at the tissue level. Okay. Patient is slightly tachypneic, give oxygen support. And what all monitors you have to attach? Fast, ECG, BP, SpO2, but don't waste time. Whatever monitors you have to apply fast. Immediate should be secure 2 large bore cannulas. Why 2 large bore cannulas? 1 for the fluids, 1 safe for the infusions. Okay, 2 large bore cannulas and push the cristoid. NG tube and Follis will be taken care of later. Damn. How much crystalloid to push? Adult 1 liter, for children 20 ml per kg bolus. And then see the response. If there is a rapid response, that means less than 20% of the blood volume only patient has lost. That is less than 750 ml. And patients might need surgery. No more bolus required. Just observe. If you push the bolus and the patient again gets back the hypotension or tachycardia, that means your patient has lost somewhere more than or around 1500 ml of blood. Surgery is needed, PRBC is needed. If the patient is showing no response, don't waste time. You might lose this patient. Hurry. Call the surgeon or get associated with the surgeon and try your level best to save the patient. Fluid of choice, RL is the first choice, but again, we are developing. If you get a BSS, that will be boon to the patient. Nothing is normal about normal saline. Please refrain yourself from normal saline. And if indicated, blood should be replaced with blood as per the hemorrhagic protocols. We have troubleshootings because crystalloids, pushing a lot of them can cause hypothermia and coagulopathy. The corrections are give warm fluids whenever massive volume push, consider these products. And Trenexa within an hour, there's a recent study, CRASH 2 trial in 2010. They have shown survival benefit of giving 15 milligram per kg Trenexa within an hour of receiving a trauma patient. And there's a concept known as permissive hypotension. It just rotates around few things. You have to restrict the crystalloid infusion to avoid hypothermia and hence coagulopathy and hemodilution. And if needed, we can opt for a multimodal approach, vasopressors to purchase time. What are the drugs we should use? Basically, vasopressors are double-edged sword, right? Apart from bargaining time for you to transfuse the volume or get the surgery done, they causes further vasoconstriction at the tissue level, further increase in acidosis, and further worsening of the physiology. So, what करना क्या चाहिए हमें? Multimodal approach. NORAD use करना है, अपनी dose पे use करो. Add electrolytes, correct acidosis. Yes, soda vita definitely you can use. And all these patients' stress will be having a poor glycemic control, and that hyperglycemia will be causing vasoplagia. You address in a multifocal manner. Apart from vasopressors, hit the electrolytes, hit the pH, and hit the RBS. So these are the special situations we have to consider. And now still your patient is not responding. There is an occult bleeder that hasn't been addressed yet, either in the retroperitoneal space or there's an internal organ injury, or there might be a myocardial injury or tamponade and tension pneumothorax. The USG will tell that and you respond quickly. Conclusion is catching early in a normotensive stage is a game changer. Volume resuscitation as soon as possible and watch the response, and immediate diagnosing the site of the bleed with fast and early surgical correction saves the life. Thank you.
Thank you, Dr. Karan, for highlighting these important points about the shock and trauma. You have given a very informative talk about the pulse oximetry, which we are using very frequently. And today I learned that PI is so important to take this shock in the trauma patient. So thank you very much, Dr. Karan. Now the next speaker is
Shitish sir. But I would like to request Dr. Sarita ma'am to kindly facilitate Dr. Karan's questions.
So our next speaker is Dr. Chipis. He is a professor in the neurosurgery department, and his talk is
secondary brain injury in neurotrauma patient.
Slide change. Slide change. Slide change.
So good morning everyone. After so many wonderful discussions by Dr. Karan Washik, I listened, and probably multiple sessions have been done in the morning regarding trauma. So now we are going to address the top story of our morning lecture. So I just want to keep it simple, not high number. I want to keep it interactive. Whenever you find there is some gap, so someone here has to just you are welcome to just ask. So most of the time when we are sitting in a trauma center and we see any patient after trauma, the patient itself tells you, right? It's for trauma because the patient is unconscious. So when we are seeing an unconscious patient after the trauma, it is very much obvious that the patient might be having headache. But many times we encounter a patient who are conscious. And in those patients, there are certain histories, certain examinations by which we can say that probably this particular patient is a patient of a head injury, and at least this particular patient needs a CT scan to rule out whether this patient is having head injury or not. So we simply ask that there is a history of loss of consciousness, there is vomiting, seizures are there or not, any history of ENT bleed from the ear, nose and throat, severe headache, amnesia, or confusion. These are the simple questions by which we will be able to assess whether your patient is having head injury or not, and if any of these things are present, then you might require a CT scan just to rule out whether this patient has a head injury or not. Altogether, there are two kinds of injuries. There are two kinds of injury. One is the primary head injury, another is the secondary head injury. Primary head injury means the injury which has already occurred at the site of accident. For example, a patient is going somewhere with pipe, had a trauma, and after the trauma, he sustained a fracture here, he sustained a small contusion there. So this is the primary injury which has already happened, and you cannot do anything for this primary injury because it has already happened. The only thing is that you can educate the mask, use helmet, seatbelt, so as to avoid the primary injury. But once the primary injury has already taken place, you cannot do anything. You can't do anything for this primary injury. Now you receive a patient with a primary injury. The patient is suppose GCS 13 or 14. On the CT scan, there is a fracture here. On the CT scan, there is a small removal. GCS is 13 or 14. You admit the patient, and after admission, this particular patient deteriorates to GCS 8 or 9. So can anyone tell me why this patient has deteriorated after admission for 4 to 5 hours? Because there is something happening inside the brain which has led to deterioration. What something has happened? You deteriorated. A patient who was in GCS 14 or 15, admitted, CT scan done, there was a fracture, there was a frontal contusion there. After 4 or 5 hours of trauma, this patient deteriorated to GCS 9. What can be the possible reason for deterioration? Anyone? So one is probably there is an increase in head injury. लेकिन head injury कैसे बढ़ेगा? Head injury तो already हो चुकी है. क्या हुआ? Why this particular patient has deteriorated? And this is a very common finding. Trauma center में जब हम लोग patient देखते हैं ना, तो many times we see the patient आया तो conscious था, and after 3 or 4 or 5 hours देखा patient और deteriorate कर गया, जिससे और चले गए. So what can be the possible cause of deterioration? Hypoxic brain injury. Very good. So in most of the cases, that particular patient has not deteriorated because of head injury. That particular patient has deteriorated because of the hypoxic brain injury. कैसे हो गई? क्योंकि trauma का patient था, nobody has cared कि उसका airway clear है कि नहीं है. Nobody has looked कि patient को vomiting आई है, aspirate भी कर गया है, and that particular patient has deteriorated because of hypoxic brain injury and not because of head injury. So that is the secondary head injury that's deteriorated. And is the reason all the patients deteriorate apart from this hypoxic brain injury because of airway occlusion.
collapse to small frontal condylum collapse with each other.
Any other thing, yes, that is the possibility. Any other thing. One is hypoxic injury, I totally understand. कि patient आया, ठीक ठाक patient था, 4 घंटे 5 मिनट patient deteriorate कर गया, just because we have not monitored the airway and because of the air infection escalate कर गया, vomiting हो गई, hypoxic injury हो गई, patient deteriorate. What else can cause patient deterioration? Shock, very good. So it is a ischemic injury to the brain. The patient may deteriorate because of the hypoxic injury. There is also a possibility that patient आया, nobody has bothered कि आपका BP check करते, nobody has bothered कि आप देखें patient shock हो रही है. And after 4 to 5 hours of trauma, even after admission in the casualty center, the patient has deteriorated just because उसका BP down था, patient shock में था, nobody has monitored and the patient has deteriorated because of the ischemic injury to the brain. So, what are the causes of secondary brain injury? Most of the time it is hypoxic brain injury. Sometimes it is also the ischemic injury to the brain. So for me, for you all as the anesthetist, as the internist, as a trauma surgeon, always try to prevent the secondary brain injury by simply saying that patient may not deteriorate because of the hypoxic to the brain, patient may not deteriorate because of the ischemic to the brain. अगर आपने ये दोनों चीज उस पेशेंट के कवर कर ली, believe me, in 50 to 60% cases में कुछ और करने की जरूरत नहीं. Head injury के patient के अंदर the only thing which has to be monitored is that the patient should not develop the hypoxic injury, the patient should not develop the ischemic injury to the brain. 50-60% काम इसलिए हो जाएगा. Next cause of deterioration is definitely the raised infection that we will discuss कि भाई raised ICP या entry पर से patient के अंदर. But in majority of the patient deteriorates because of the hypoxic injury and the ischemic injury. अगर आपने ये rule out कर लिया तो 30-40% के अंदर patient can deteriorate because of the raised ICP that will look after. So the primary goal of treatment, तो आपका जब कभी कोई patient whenever you see any patient of a head injury, your primary goal is to prevent the secondary brain. क्योंकि primary injury has already taken place, अगर आप किसी तरीके से उसकी secondary brain injury prevent कर लेंगे, then that particular patient will gradually improve. और कैसे secondary brain injury prevent करेंगे? By preventing hypoxic injury, by preventing ischemic injury, and by tackling the raised injury pressure. और hypoxic ischemic injury कैसे prevent करेंगे? By simply filling the airway, breathing, circulation, and that is the importance of a primary survey in a patient of a trauma, in a patient of an acute trauma. By simply managing airway, breathing, circulation, you can manage at least 60% of the patient of the head injury by preventing secondary brain injury. Rest of the 30-40% you can manage by simply managing the raised blood pressure. Now another thing is how to assess. अब आपका कोई patient आ गया, you have an idea that this particular patient के अंदर primary injury हो गई है. My aim is to detect or to manage the secondary brain injury. You have detected the patient, you have detected the head injury patient by seeing that patient या तो unconscious है और इसके अंदर जो clinical signs थे, you assess कर ले कि हाँ ये patient का head injury. Now your next aim is to assess how severe is the head injury. कैसे करते हैं severity? Very good. So we assess the severity of the head injury by noting the GCS score of the patient, and we all know the GCS score has 3 components: eye, verbal, motor. सबको पता है ना GCS score? No need to revise. So by assessing the GCS score of patient, we can have an idea कि patient को mild head injury है, moderate head injury है, severe head injury है. Mild head injury है, it means that this is the patient which requires some amount of observation. Based on the radiology, based on the status, आप observe करते हैं, patient को करते हैं. Moderate head injury is for me is the most important patient because this is the patient जिसके अंदर अगर आप अच्छे तरीके से ABC मैनेज कर लेंगे, raised ICP को टैकल कर लेंगे, so this is the patient which is going to improve. Severe head injury, as the name suggests, कि काफी severe head injury है, prolonged unconsciousness, prolonged समय तक ICU care, prolonged समय तक bedridden रहते हैं, and for this kind of patient we always say whenever you see any patient of a severe head injury, with Jesus 8 or less, always intubate the patient, ventilate the patient because in such cases airway compromise is सबसे ज़्यादा probability. So whenever you see any patient of a severe head injury, always intubate the patient. Now, एक बार आपने patient देख लिया, assess कर लिया कि उसको head injury है कि नहीं है, assess कर लिया कि कितना severe head injury है, your next job is to confirm कि वैसा head injury है कि नहीं है, और you or that you need a CT scan. Now the question, कई बार लोग आते हैं कहते हैं कि सर CT scan देखें कैसे, और कई बार कहते हैं कि साहब I am not a radiologist, I am not a neurosurgeon, just tell me कि कुछ findings CT scan दे करके at least हम ये बताएं कि ट्रॉमा को था. So what I just want to say कि whenever you are going to see a CT scan and any patient of a trauma, you know CT scan अंदर कट्स होते हैं. तो जैसे यहाँ पे 2 कट्स हैं, 2 साइड से कट्स. तो these are the basically cuts. एक स्टॉप फिल्म होती है जिसमें नंबर कट्स लिया जाता है. तो जब कभी भी आपको बोला जाए कि इन ट्रॉमा पेशेंट आपको सीटी स्कैन देखने हैं तो ऑलवेज रिमेंबर द 3C. 3C क्या है? These 3C are basically the white thing inside the CT scan. So first C is contrast. CT scan में अगर आपने कंट्रास्ट दिया है तो कंट्रास्ट आपको व्हाइट दिखाई पड़ेगा. ट्रॉमा सेटिंग में क्या करते हैं कि वी नेवर आस्क फॉर ए कंट्रास्ट CT scan. We always ask for a non-contrast of the plain CT scan. तो first C is out of question. अब बचे 2C. Second C or the second white in CT scan is calcification, and calcification and bone basically bhalo. And with our anatomy knowledge हमको पता है कि bone कहाँ पर है. So for in this CT scan जो यहाँ पे दिख रहा है, इसके अंदर bone is basically in the outer margin. तो ये जो white light दिख रही है, this is basically the bone. This is the second C. ठीक है? तो इस CT स्कैन के अंदर सेकंड सी में यू आर सीइंग कि ये जो व्हाइट दिख रहा है ये बोन है, एंड उसके अलावा व्हाटएवर व्हाइट इज इनसाइड द CT इट इज जस्ट ए क्लॉट नथिंग हियर, दैट इज थर्ड सी. तो अगर आपको कोई बोले ये CT स्कैन के अंदर ये नॉर्मल है क्या नॉर्मल है, तो क्या बोलेंगे? नॉर्मल अपना मुल्ला अगर कोई आपसे ये पूछे कि इस CT स्कैन के अंदर क्लॉट है कि नहीं है, तो व्हाट विल से? नो क्लॉट. क्यों? क्योंकि कंट्रास्ट दिया नहीं है, ये प्लेन CT स्कैन है. सेकंड CT स्कैन के अंदर कैल्सिफिकेशन और बोन आउटर मार्जिन है जो कि नॉर्मल है, कहीं कोई फ्रैक्चर वगैरह नहीं दिख रहा है. और थर्ड CT स्कैन के अंदर इनसाइड द ब्रेन की पैनोरामा देयर इज नथिंग राइट, तो नो क्लॉट इनसाइड. इसका मतलब कि ये नॉर्मल CT स्कैन है ट्रॉमा के पेशेंट. नाउ अब बात आती है कि जब आपने ये देख लिया कि हमको व्हाइट पीस देखनी है, तो नेक्स्ट क्वेश्चन इज कि व्हाइट पीस आपको CT स्कैन में कहां देखनी है. तो अगेन जस्ट मेमोराइज इट कि there are 5 locations in the CT scan जहां पे आपको प्लॉट को आइडेंटिफाई करना है. नंबर 1 आउटसाइड द ड्यूरा, क्या हो गया? एक्स्ट्राड्यूरल हेमाटोमा. नंबर 2 इनसाइड द ड्यूरा बट आउटसाइड द ब्रेन पैरेन्काइमा, that is the subdural hematoma. Means the plot between the dura and the brain parenchyma, that is the subdural hematoma. Third location is inside the brain parenchyma, we call it the contusions. Fourth location inside the ventricle, we call it as a intraventricular hemorrhage. And fifth location is the subarachnoid hemorrhage, that is in the subarachnoid hemorrhage. So 5 location है outside the dura, extradural, inside the dura but outside the brain, subdural, inside the brain parenchyma, brain contusion. The 2 location inside the ventricle, intraventricular hemorrhage, and in the subarachnoid space, that is the subarachnoid hemorrhage. तो ये 5 लोकेशंस होती है, इस स्कैन में देख सकते हैं. फर्स्ट लोकेशन आउटसाइड द ब्रेन, मतलब आउटसाइड द ड्यूरा, इनसाइड द बोन, टिपिकल शेप, that is the extradural hematoma. Second location between the dura and the brain, तो ड्यूरा और ब्रेन के ऊपर होंगे तो इसमें की क्लॉट पूरी की पूरी ब्रेन सरफेस को स्प्रेड कर जाएगा. तो ऐसी करके पिक्चर दिखाई पड़ी, that is extradural hematoma. Third, white thing inside the brain parenchyma, based on location आप बता देंगे कि it is a frontal contusion or a temporal contusion or what is the location. Fourth, inside the ventricle, intraventricular hemorrhage, and fifth is the blood in the system, that is the subarachnoid space. तो यही 5 देखनी है. And in most of the cases, whenever you see any patient, any radiology, any trauma, you will find a combination of these things. Means कि किसी पेशेंट के अंदर होगा सबड्यूरल होगा, साथ में कंटिन्यूस होगा, साथ में सबरैक्नोइड हेमोरेज होगा, ये आईक्यू. That is basically the combination. But सिर्फ ये 5 बेसिक चीजें होती है which you have to see in the CT scan just to identify whether that particular patient is having any condition. यहाँ पे कोई query, कोई question, कोई confusion? Now once you have identified कि भाई आपका पेशेंट है, आपने उसको असेस कर लिया कितना सीवियर उसकी हेड इंजरी है, हाउ सीवियर है हेड इंजरी, by getting a CT scan you are able to identify कि भाई पेशेंट के जीसस भी डाउन है, and in the CT scan I am able to see those white things, it means कि there is a clot. Now next question आता है कि if you are sitting in the ICU, रात को 2 पेशेंट आया, न्यूरो सर्जन को कॉल करना नहीं करना. It means कि by seeing the radiology you need to decide how significant is this condition. क्योंकि कंडीशन जो होगा वो हो सकता है छोटा भी हो, कंडीशन ऐसा भी हो सकता है कि ज्यादा प्रॉब्लम वाला ना हो, और कंडीशन ऐसा भी हो सकता है कि इट नीड्स रिक्वायर्ड इमीडिएट इंटरवेंशन। इट मींस कि by seeing the radiology you need to decide कि how severe, how significant is this category, how significant is this trauma. कैसे देखेंगे? So what we call it as a, you need to find out the evidence of raised intracranial pressure inside the CT scan. CT scan से plot देखते हैं, ये पता लग गया hereditary है. Now you need to find the evidence of raised intracranial pressure inside the CT scan. क्या क्या evidence होते हैं? So there are overall 4 evidence. These are the 4 evidence जिसको आपको देखना है, and based on these 4 evidence you will decide कि patient को radiological raise ST है. So what are those 4 evidence? One is effacement of the ventricle. Whenever there is a clot, it will compress the ventricle. So effacement of the insulated ventricle. Second is midline shift. Clot अगर होगा तो पूरा brain को shift कर देगा. Second is the midline shift. Third is the obliteration of sulci. There are sulci spaces. So whenever there is a raised ICP, all those sulci will be obliterated. And fourth is the obliteration of this. What is system? System is the CSF space all around the brain. So even when these CSF space all around the brain stem is not visualized, they are obliterated. It means there is a raised ICP. So these are the 4 features by which you will be able to say that radiological उसको raised ICP है कि नहीं है. So first is vertical effacement. Vertical एक तरफ छोटा दिख रहा है, दूसरी तरफ normal दिख रहा है. Second is the obliteration of sulci. You can see कि one side normal sulci black thread is serving, and the opposite side sulci are obliterated. Raised ICP on the opposite side. Obliteration of vessel system all around the brain stem. You are not able to visualize any black CSF ring. So obliteration of the vessel system. And fourth is basically the midline shift. So based on these 4 findings, you can say कि भाई patient को heredity तो रही है. But there are radiological evidence of raised ICP, so this particular patient is serious. I need to call the neurosurgeon because this particular patient requires intervention because these are the findings which are able to see. What confusion? Okay. Now, once you have identified that your particular patient has hereditary by looking at the GCS code, once you have identified that your patient has hereditary by looking at the CT scan, you have also identified by looking at the CT scan how significant is the radiological finding by seeing the evidence of raised ICP. Next job is to manage the patient. Believe me, you don't have to do anything to manage because the brain heals by itself. It only requires the time to heal. कुछ addition नहीं कर सकते because brain is something जिसका आपको time देना है. It will heal by itself. It simply requires some time to heal. Your job is simply to prevent the secondary brain. Just prevent the secondary brain. कैसे prevent करेंगे? कैसे prevent करेंगे secondary brain? By managing A, B and C, airway breathing circulation, and by managing the rate. अगर आपने इतना कर दिया, तो आपको कुछ और करने की जरूरत नहीं है. You simply have to observe, and the brain will take its own time to recover. Will take its own time to. So general management क्या होगा? Just maintain the ABC. Maintain the normal metabolic parameters, sugar है, fever है, whatever it is, just को maintain करना है. Head elevation थोड़ा करना है. IU fluids देने हैं. Always try to maintain the U volume. Never give the hypotonic fluid. क्यों hypotonic देते हैं? Hypotonic fluids are contraindicated. क्यों? ICP कैसे बढ़ेगा? ICP ऐसे बढ़ेगा because whenever you give any hypotonic fluid, because of the low colloid osmotic pressure, some of the water from the intravascular compartment will go into the extravascular compartment inside the brain cell, and it will raise the pressure inside the brain. So never give the hypotonic fluid. Always try to give the isotonic fluid to the patient of a hereditary. Whenever the patient is on ventilator, your goal is to maintain the PaCO2 at around 35 millimeters per mercury. Why is 35? ज्यादा होगा क्या होगा, कम होगा क्या होगा, तो समझ ज्यादा होगा क्या होगा. So in our physiology classes जब लोग पढ़ते थे physiology में, तो PaCO2 के बारे में पढ़ा करते थे कि PaCO2 whenever there is an increase in PaCO2, it will lead to cerebral vasodilatation. So whenever there is cerebral vasodilatation, it means the extra amount of blood will stay inside the brain. And whenever there is an extra amount of blood that will stay inside the brain, it will lead to brain pressure. इसका ऑब्जर्व करना है कि whenever there is a low PaCO2 means the cerebral vasoconstriction, And when there is a excessive vasoconstriction, it will lead to cerebral ischemia. तो इसका मतलब कि PaCO2 ज़्यादा भी गड़बड़, it will lead to raise ICP. PaCO2 कम भी गड़बड़, it will lead to cerebral ischemia. So your job is to maintain the PaCO2 at around 35 mg/L whenever your patient is on ventilator. To reduce it, you have to, whenever there are signs of raise ICP, you have to reduce the pressure, and for that you reduce it medically by giving several dehydrates in the form of either mannitol or hypertonic saline used to control the blood pressure, used to control the raise ICP. Apart from that, what are the other medications which are required? So you require to give anticonvulsant because there is always the possibility of either any patient of a headache in the initial week. So you have to give the anti-epileptic, you have to sedate the patient, you have to paralyze the patient because most of the time these are patients which are very much irritable. Surgery, when to do surgery? Anyone?
The midline should point by
No. No.
the अलग-अलग criteria होते हैं. ADH अगर मैं LCH है तो अलग.
So I would say कि कोई ऐसा criteria नहीं होता. ठीक है, सर्जरी कब करनी है? There is no clear-cut defined criteria कि midline shift इतनी तो सर्जरी करनी है, वॉल में करना है. No clear-cut defined criteria. सर्जरी कब करनी है? Iterating Jesus again not a criteria because कई बार patient ऐसा होता है कि Jesus ठीक होती है, but etiological evidence दे जाती है कि आपने जो सर्जरी करनी है. तो सर्जरी कब करनी है? When the neurosurgeons find कि you are unable to manage this patient medically. पहला एम तो होता है कि किसी तरीके से medically treat करो. Medically कैसे treat करें? General measures apart from mannitol or hypertonic saline देते हैं. ICP करते हैं. But at times surgeons say कि इस particular patient के अंदर radiological evidence of raise ICP है, significant है. और उसको ऐसा लगता है कि क्लॉट का वॉल्यूम ऐसा है, midline shift होती है कि इसके बेसिस पे शायद medical management difficult आएगा. In those cases, surgeon decide to give this is the patient which requires surgery. So, if you are not able to manage the patient medically, or you suspect that this patient may deteriorate by treating the patient medically, surgery is required. Surgery करते क्या हैं? Simply you have to remove the clot. कोई बड़ा सा clot है जो कि mass effect दे रहा है, pressure दे रहा है, you have to remove the clot. और अगर कोई बड़ा सा clot नहीं है, but you है ना closed space है, you want to just convert this closed block into open block. तो decoupling correctly करते हैं, just simply take out the bone and keep it in the abdomen, just to make it a big space, big integrated space. So this is the first indication. And second indication is that whenever there is a dural laceration, there is a brain matter leak, there is a CSF leak, that you have to operate so as to prevent the CSF leak and to prevent the meningitis to patient. So to summarize, so what should you do? You should always try to maintain the BP because you never want the patient to deteriorate because of the ischemic injury to the brain. You always try to maintain the PaCO2 somewhere near 35. Always use isotonic saline to the patient. Frequent neurological examination is must because you always want to know whether patient is deteriorating, so frequent neurological examination, and whenever in doubt, always go for a CT. What not to do? Never allow the patient to become hypertensive. Never over aggressively hyperventilate. चाहे सर्जन जितना बोले उसी के अंदर के पेशेंट को बंद कर hyperventilate करते never do because आपको PaCO2 35 का मेंटेन करना है. Use hypotonic IO fits. Never use hypotonic IO fits and never use long antipyretics. क्यों? क्योंकि आपको frequently G से assess करना है. So don't give long antipyretics. है ना? वरना फिर आप G से frequently assess नहीं करेंगे. Thank you. Any questions? Anything?
Thank you, Dr. Chittis, for a very nice and lecture on the neural management and detection.
Now I would like to request
Dr. Satish Sharma sir to kindly facilitate Dr. Satish Sharma's question.
Thank you, Dr. Chittis, for very informative and very important lecture. That was very basic but very important for the students. I hope the students will be benefited by this lecture. Thank you so much.
Now I would like to request Dr. Sarita ma'am to kindly facilitate Dr. Dinesh Singh sir. Now I would like to request Dr. Diya Rishabh sir to kindly facilitate Dr. Sarita Singh. Now I would like to request Dr. Lati Prabha ma'am to kindly facilitate Dr. Satish Verma sir.
Thank you, sir, and ma'am, and my seniors, and all delegates. Thank you. And I want to just inform ki kindly take your kids outside this hall from Abhishek and Adit, and after that you will go in room number 309. Okay, and station number is already mentioned on the kit. So go your respective workstation, and after that we will guide there. Okay, thank you everybody. Thank you so much.